हाँ ठीक है ठीक है। बंद करा देखिए, बंद हो गई मीटिंग। सीट बना दो बेशक की ये दहली खुल गई है। विंडो शेयर करा दिया अपनी। और फिर से देखिए आ रहा नहीं आ रहा है। ओके। तो टर्मिनेशन फेज में डॉक्यूमेंटेशन की मैं बात कर रहा था कि डॉक्यूमेंट कैसे करना है हमें इस प्रोसीजर को। तो इसके लिए हमें जो हमने एनजी ट्यूब इंसर्शन और फीडिंग किया है उसका डेट और टाइम हमें अपने नोट्स में डालना है। एनजी ट्यूब कौन से साइज का हमने लिया था उसको हमें नोट करना है। कौन सा नोस्ट्रल हमने यूज किया था, लेफ्ट, वेदर इट इज लेफ्ट और राइट, जो भी नोस्ट्रल हमने यूज किया है उस नोस्ट्रल को हम मेंशन करेंगे अपने नोट्स में। मेथड ऑफ प्लेसमेंट कंफर्मेशन, जो अभी हमने मेथड्स देखे थे जैसे कि एयर इनफ्लक्स एयर पुश मेथड या फिर गैस्ट्रिक कंटेंट एस्पिरेशन मेथड, जो भी मेथड हमने प्लेसमेंट को कंफर्म करने के लिए यूज किया था वो इसमें हम इंक्लूड करेंगे। टाइप, अमाउंट और टाइम फीड का इसमें हम यूज करेंगे। वाटर का जो अमाउंट हमने एनजी ट्यूब को क्लियर करने के लिए यूज किया था उसको भी हम इसमें मेंशन करेंगे। पेशेंट का टॉलरेंस लेवल भी हम इसमें चेक करके और मेंशन करेंगे। और अगर किसी तरह की कोई भी कॉम्प्लिकेशन अगर हमने ऑब्जर्व करी है ड्यूरिंग द प्रोसीजर और आफ्टर द प्रोसीजर, उसको भी हम पेशेंट के नोट्स के लिए हम इसको रिकॉर्ड कर लेंगे। तो इस तरीके से हमारा ये प्रोसीजर जो है वो कंप्लीट हो जाता है। इफ देयर इज एनी क्वेरी कैन आस्क टू मी। ओके, थैंक यू सो मच।
We are proud to have Dr. Anita Godley, ma'am, Principal, Vice Principal, Keshavata School of Nursing. Ma'am, please come as clinical committee in charge, ma'am. Vice? एक मिनट उसको ऐसे रहने दें। एक दो करेक्शंस हैं आशीष सर ने जो अभी प्रोसीजर करके दिखाया, तो वो करेक्शन मैं आपको बता दूंगी। तीन चार करेक्शन है। सबसे पहले बच्चों ये ध्यान करना चाहिए कि व्हाट इज द पोजीशन ऑफ द बेड, वेदर पेशेंट इज कंफर्टेबल और नॉट। मैं वहां से बैठी ही देख रही थी कि पेशेंट इज नॉट वेरी कंफर्टेबल। तो हमको ये ध्यान करना है कि पेशेंट को कंफर्टेबल पोजीशन हमको देनी है, और उस पोजीशन में हम पेशेंट का प्रोसीजर करेंगे। अभी हम देखेंगे वहां पे। देन एयर पुश करने के लिए प्रॉपर प्लेसमेंट, वेदर एनजी ट्यूब इज इन द प्लेस, तो उसके लिए हमें 10 ml सिरिंज हम लेंगे, नॉट 50 ml। ठीक। देन जब एनजी ट्यूब मेजर हम कर रहे हैं तो हमको इस बात का ध्यान करना है कि ट्यूब शुड बी स्टराइल। तो हमको डायरेक्टली पेशेंट के नोज पे, चीक्स पे हमको उसको टच नहीं करना है, वो हमको ऊपर से ही मेजर करना है। और क्योंकि वो स्टेराइल है, गो इनटू द स्टमक, तो इस बात का हमको ध्यान करना है। देन जब हम फीडिंग कर रहे हैं, 50 ml सिरिंज का हम इस्तेमाल कर रहे हैं, तो ओनली बैरल शुड बी यूज्ड। पिस्टन का हम इस्तेमाल नहीं करेंगे, वो अपने ग्रेविटी के थ्रू फीड जो है वो जाना चाहिए। अगर हम उसको पुश करेंगे तो वो स्टमक में वो प्रॉब्लम करेगा, ब्लीडिंग हो सकती है, ये प्रेशर पड़ेगा तो ये प्रॉब्लम हो सकती है। देन इसके लिए हम फनल भी यूज कर सकते हैं। अगर हमारे पास 50 ml सिरिंज नहीं है तो फनल का भी हम इस्तेमाल कर सकते हैं। देन लास्टली हमको हमारे पेशेंट को हमको टीच भी करेंगे। आजकल आपको मालूम है कि कैंसर बहुत ज्यादा हो रहा है, और ओरल सर्जरी अगर पेशेंट की हुई है तो पेशेंट विल लिव लॉन्गर इन एनजीट्यूब। तो उस समय हमको सेल्फ फीडिंग कैसे कराना है वो भी हम पेशेंट को अपने सिखा सकते हैं। तो बता दो। हाँ, ठीक है। एक करेक्शन और है, जो लूप है, जो ट्यूब है, वो बहुत ज्यादा फेस पे नहीं आपको टक करना है, क्योंकि वो अच्छा सा नहीं लगता है। एस्थेटिक पॉइंट ऑफ व्यू का भी हमको ध्यान करना है ना। तो ये भी हमको देखना है, और बहुत बड़ा बड़ा नहीं लगाना है, इतना कि अच्छे से सिक्योर हो जाए नोज पे, है ना। इस बात का हमको ध्यान रखना है। पेनड्राइव लगाइए, पेनड्राइव लगाइए, उसमें जो ना भी बैठेंगे तो सेफ काम कीजिए। अरे सर, जो आज की है डिस्प्ले नहीं होगा ना, कि पीपीटी उसमें पेनड्राइव में लगाइए।
Thank you so much, sir, for such an interactive procedure demonstration on nasogastric tube insertion and feeding. Now, for diving deep into the topic of catheterization and insertion care in male patient, I humbly call Mr. Akansh Alexander, Assistant Professor, Rohilkhand College of Nursing. He's MSc Nurse in Mental Health Nursing, 7+ years of professional experience, including clinical and teaching. His research and academic work has several publications in national and international publication. He is research guide, examiner, paper setter, and evaluator in university and university observer at Atal Bihari and VIU. And workshop, he has attended many workshops and conferences. In their workshops, he has been facilitator, organizing speaker, delegate in international and national workshops. Sir, please come.
A very good morning to respected Principal Ma'am and Vice Principal Ma'am, Rohilkhand College of Nursing, and respected Principal Ma'am and Vice Principal Ma'am, Lata College of Nursing, and my dear faculty members. Now I'm here to present my presentation on male catheterization. So at the end of the session, all the participants will be able to define the reasons why male urethral catheterization may be necessary and state the common risk factor that may arise as a result of procedure being carried out, and discuss the reasons why insertion of urinary catheter in male patients may be contraindicated, and describe the process of inserting a urinary catheter in a male patient, and describe the information required for the completion of patient care and documentation. So here's the definition of catheterization and catheter. So catheterization basically is a medical procedure in which a thin flexible tube called a catheter is inserted into the body to drain fluids, deliver fluids or medication, or to perform diagnostic tests. And for example, what I will explain today is urinary catheterization. It is a catheter which is inserted into the bladder through the urethra to drain urine, retented urine. Basically, there are three types of catheters: indwelling catheter, which we commonly call Foley's catheter, which remains in the bladder, and second type is intermittent catheterization, which is temporarily used and inserted temporarily to empty the bladder. And third type is suprapubic catheterization, which is inserted surgically through the abdomen. And fourth type is also that a condom catheter, that is also a temporary catheter. What are the indications for catheterization? हम catheterization क्यों prescribe करते हैं patient को? सबसे पहला indication है urinary retention. So urinary retention is retention of urine can be caused by mechanical urethral obstruction or neurological disorders avoiding affecting voiding. यानी कि जो भी यूरिन हमारी किसी भी मैकेनिकल यूरेथ्रल ऑब्स्ट्रक्शन की वजह से हो जाती है, तो जो रिटेंडेड यूरिन है उसको ड्रेन करने के लिए इट इज इंडिकेटेड. Then second is for monitoring urine output, and in a number of different clinical conditions, including shock and renal failure, is it desirable to accurately measure hourly urine output to calculate accurate fluid balance. And third is the patient who are unable to void urine in the normal manner. Unconscious patients, unconscious patients undergoing operative procedures, or those with particular injuries, urethral injuries, and featured neck of femur, fractured neck of femur. And it is also used for bladder irrigation. It is used in prostatic operative procedure, often require post-operative irrigation to prevent clot retention of the urine. जो भी bladder में post operative का clots रह जाते हैं उनको retain करने के लिए भी. And also for medical administration, जो भी मेडिसिन इंट्रा वेसिकली हमको यूज करनी है वो हम कैथेटर के थ्रू भी यूज कर सकते हैं. मेडिकेशन सच एज कीमोथेरेपी एजेंट्स में रिक्वायर्ड टू बी एडमिनिस्टर्ड इंट्रावेसिकली. Now there are the contraindications. Urethral stricture. It is typically caused by scar tissues narrowing the urethral lumen and making passing a catheter difficult or even impossible. Urethral stricture basically क्या होता है कि हमें जब भी यूरेथ्रा में कोई ट्रॉमा हो जाता है या फिर ब्लीडिंग हो जाती है उस कंडीशन में हम कैथेटराइजेशन पेशेंट को डायरेक्टली नहीं दे सकते हैं. इट इज कॉन्ट्राइंडिकेटेड. देन if the blood is coming out of urinary meatus in the presence of trauma suggests a possible urinary tract injury, and imaging must be conducted to establish the extent of any such injury before attempting catheterization. तो बेसिकली हमको ऑब्जर्व करना है किसी भी टाइप की इंजरी या ब्लीडिंग को, और अगर ज्यादा है तो हम उसको दैट इज कॉन्ट्रा इंडिकेटेड इन दैट पेशेंट. Now here comes a case scenario related to catheterization. Mr. Rajesh Kumar, a 68-year-old male, was admitted to the surgical ward with complaint of severe lower abdominal pain, inability to pass urine for the last 10 hours, restlessness and abdominal distension and discomfort. On assessment, the nurse will observe a distended bladder and a pain score of 8 by 10, and vital signs are stable. So here the case scenario suggests about catheterization. So before diagnosis, I would like to tell the color coding of the catheter. So there are different color codes of the catheter. So we recognize catheter according to its color. So from 6 to 10 French, जो भी साइज होता है वो हम फ्रेंच में गिनते हैं कैथेटर का. तो 6 to 10 इट्स प्रेफरेबल फॉर द pediatric या बच्चे के लिए. Then 12 to 18 for adult males and also for females, and then 14 to 20 for 18 for females preferable, and 14 to 20 for adult males. And 22 to 26 is used for basically irrigation of the bladder in condition of post-operative of prostate glands and other surgeries. Now the nursing diagnosis according to the case scenario will be like pain related to bladder distension and urinary retention as evidenced by severe lower abdominal pain, restlessness and discomfort. And next is impaired urinary elimination related to urinary obstruction, inability to pass urine for 10 hours, and abdominal distension as evidenced by urgency, frequency, and dysuria and urine retention. And also the patient will undergo the anxiety related to hospitalization and inability to void urine as evidenced by restlessness and anxious behavior. There will be a risk of infection related to invasive urinary catheterization procedure evidenced by irritation at the insertion site, and disturbed comfort related to abdominal pain and urinary retention as evidenced by verbalization and discomfort of the patient. यहाँ पे पार्ट्स दिखाए गए. बेसिकली टुडे आई विल एक्सप्लेन द catheterization using a Foley's catheter. What that it is basically used in males and females both. So female catheterization will explained by my colleague Mrs. Anju, and I will tell about male catheterization. Now here are the parts of Foley's catheter. So here is a tip of the tip of the catheter, which is called bladder opening. There is a little opening which will cause urine to retain from the bladder. And it has a balloon to inflate and to fix in the bladder. And at the top, there are two sections. One is urinary drainage port and one is balloon inflating port. Here are the articles. We use two types of tray, one clean tray and one sterile tray. Clean tray में हम urinary drainage bag रखेंगे, waterproof Macintosh रखेंगे, disposal gloves रखेंगे, adhesive tapes to fix the catheter, kidney tray, measuring container if needed for urine samples, tissues or towels, and adequate light sources if light is uh, dim or there is no availability of light. Then we make a sterile tray using catheterization kit, gloves, drapes, urinary catheter, anesthetic lubricant jelly, antiseptic solutions like povidone iodine or chlorhexidine, sterile cotton balls, swabs, and gauze pieces, syringe prefilled with 10 ml of normal saline to inflate the balloon, and RT's forceps if included in the kit. सबसे पहले हमको प्री प्रोसीजर एक्सप्लेन करना है पेशेंट को, और हमको क्या क्या प्री प्रोसीजर में हमें कंटेंट याद में रखना है। फर्स्ट वी हैव टू ऑब्टेन कंसेंट फ्रॉम द पेशेंट। सबसे पहले हम क्या करेंगे, पेशेंट से किसी भी प्रोसीजर से पहले हम उसको कंसेंट हमको लेना है पेशेंट से। देन वी विल एक्सप्लेन द इंडिकेशन फॉर द प्रोसीजर ऑफ द पेशेंट, कि पेशेंट को क्यों ये प्रोसीजर दिया जा रहा है, उसको प्रॉपरली हमको एक्सप्लेन करना है कि आपको यूरिन यूरिन पास करने में दिक्कत हो रही है तो उसके लिए हमको आपको कैथेटर इन्वेजिव मेथड के थ्रू डालना पड़ेगा। देन उसको उसके सारे कॉम्प्लिकेशंस के बारे में भी बताना है कि आपको पेन भी हो सकता है, थोड़ा या डिस्कम्फर्ट हो सकता है, एक्सप्लेन करना है प्रॉपरली। देन एक्सप्लेन हाउ लॉन्ग द कैथेटर विल बी रिक्वायर्ड, कितने लंबे समय तक पेशेंट के कैथेटर डलेगा, उसकी केयर को प्लान करना है हमको उसको आगे। एंड देन ऑल्सो और चेक करना है उसको एलर्जी, बिकॉज देयर आर टू टाइप्स ऑफ कैथेटर, एक लेटेक्स कैथेटर होता है और सिलिकॉन वाला। तो कई लोगों को क्या होता है, लेटेक्स रबर से उसको एलर्जी होती है। तो एलर्जी जिसको पेशेंट, फर्स्ट वी हैव टू चेक द एलर्जी फॉर द लेटेक्स, देन वी हैव टू डिसाइड विच कैथेटर वी हैव टू यूज, लेटेक्स और सिलिकॉन कैथेटर। तो बेसिकली सिलिकॉन कैथेटर जो है वो लंबे समय के लिए हम पेशेंट के अंदर डाल सकते हैं, क्योंकि वो जल्दी उसका खराब नहीं होता है और उसको जल्दी चेंज करने की हमको अर्जेंसी नहीं रहती है। सो वी हैव टू चेक द एलर्जी फॉर लेटेक्स inside the patient. Now here are we start the procedure. Today I will explain the steps of the procedure, then I will demonstrate on the dummy. So सबसे पहले we have to verify the physician's order, और पेशेंट को करेक्टली आइडेंटिफाई करना है उसके टैग नंबर से, उसकी फाइल से। ओके मैम।
हम किताब की जमीन में हम पैसे पूरे रखता पूरी डालेंगे, जिसकी वजह से हम आपके किताब को जो डिटेक्टिव and you follow all the steps. जो बोल रहे हैं वो then you will see love. Yeah, something else. What is what I mean? So once you clean class, we will attend the patient and provide a supine position. So we use two mouths. In one mouth there will be a clean or warm water, and in one mouth should be water to clean the perineal area before you perform the sterile procedure. So हम तक मुसलमान दोस्तों के पेशेंट को उसके बाद उसके नीचे मैजिक टॉर्च प्लेस करेंगे ताकि हमारी बॉडी जो है वो स्पॉइल ना हो। And then we'll place a drape sheet on the magic torch. प्रोफाइल। तो quickly frame quickly make the part computation to collect the oil after the first we hold the pen सबसे पहले प्रोसीजर है क्या? हाँ सबसे पहले हमको होल्ड करना है पेन इसको 90 डिग्री पोजीशन पे ताकि जो लिखा है वो स्ट्रेटन हो जाए और कैलकुलेटर शिफ्ट हो जाए। देन फिर उसके उसके फोर्स स्लिप को हमें रिट्रैक्ट करना है अगर सर्कम साइज नहीं है तो। फिर आपको क्लीन वाटर से क्लीन करना है अपर एरिया आउटवर्ड लेते हुए इनवर्ट टू आउटवर्ड मीटर और फिर डाउनवर्ड लेते हुए उसको क्लीन करना है क्लीन वाटर से। देन उसको सोपी वाटर से उसको सोपी वाटर से क्लीन करना है। इसको रिपीट करना है हमको 2 to 3 टाइम्स। देन we have to ready for sterile procedure ये भी हम उतारेंगे। Now we will open the sterile ring during on-rolling process. Then we will cover the patient genital area with a whole of penetrated drain sheet। यानी यूज होगा पेशेंट का जब हम पेशेंट बैग हटाएंगे तो उसको हटाना है। Now you will get sterile
मैंने क्या जरूरत है?
Now we cover the anti-captive solution।
मैंने दिखाया था ना कि होता है कैसे आपको सारा करके करना है कि आपको असिस्टेंटली को कैसे करना है इसलिए मैंने पहले सिखाया है वैसे फॉलो करना आपको असिस्टेंट की जरूरत नहीं पड़ेगी। आप नहीं छू सकते हो स्टाइल चीजों को उनको दो। अरे आप नहीं छू सकते हो स्टाइल चीजों को अनस्टाइल चीजों को। आपने ग्लव्स पहने हैं स्टाइल
जब sterile कर लेंगे एंटीबायोटिक पर एंटीसेप्टिक सॉल्यूशन से फिर होल्ड करेंगे, होल्ड करके और इनर टू आउटवर्ड एंड डाउनवर्ड and again the power the line. One stop or one. Okay. There are two types of process. One is artery, one is pump. You have to use both the things. Now. But would you indicate that 5 to 7 inches? With lubricant daily. Then we'll again hold a pen represented with both pin and insert that using in a slightly slow and circular motion, and we'll descend the tube till 15 to 25 centimeters till the urine comes in the catheter and tube, and then we have to clamp the catheter for urine outlet to avoid spilling of the urine. Then we'll extend more 1 to 2 inches and then we'll inflate the balloon with 10 mm normal balloon to fix the catheter in the blood. Then we'll check, हम बाहर पर निकाल के चेक करेंगे, अगर वो फिक्स हो गया है तो keep solution inflated and we'll fix the urinary bag. Urinary bag to the catheter. कैथेटर को इनर एस्पेक्ट ऑफ द थाई पे हम इसको सिक्योर करेंगे जिसको ताकि कैथेटर ब्लैडर से बाहर ना निकले. जहाँ पे पूरी फुल डमी होगी इसको हम यहाँ पे सिक्योर करेंगे और ब्लैडर को पकड़ के रखेंगे. सिस्टम को ब्लैडर को हम ब्लैडर की पोजीशन से नीचे टांगेंगे ताकि बैक फ्लो ना हो उसका. फिर इस रेप शीट को हटाएंगे। पेशेंट को कंफर्टेबल पोजीशन दोबारा से देंगे और टू मैकिंटॉश एंड so this is the procedure for catheter insertion and after carrying the catheter to care हमको जब पेशेंट को इरिटेशन फील होने लगती है फुल जैसा डिस्कम्फर्ट होता है तो कैथेटर केयर हम कैथेटर में दोबारा से हम टेप को सिक्योर करके फ्री कर देंगे ट्यूब को 90 डिग्री एंगल पे हम दोबारा से फिर उसको होल्ड करेंगे शाफ्ट से फिर एंटीसेप्टिक सॉल्यूशन से सेम मोशन में इनवर्ड टू आउटवर्ड एंड डाउनवर्ड पोजीशन में एंटीसेप्टिक सॉल्यूशन से साफ करके सलाइन बटन से साफ करके हम उसको स्मूथ ऑफ कर देंगे दोबारा। और अगर एंटीबायोटिक उसका लोशन या फिर ऑइंटमेंट की जरूरत है डॉक्टर से प्रिस्क्राइब मिलेगा। एक सर्कुलर मोशन में हम एंटीसेप्टिक सॉल्यूशन से मीटर से लेकर आउटवर्ड आउटवर्ड और डाउनवर्ड डायरेक्शन में हम क्लीन करेंगे। और ऑइंटमेंट अगर एंटीसेप्टिक ऑइंटमेंट की जरूरत है किसी डिस्कम्फर्टेड पेशेंट डॉक्टर ने प्रिस्क्राइब कर दिया तो उसको अप्लाई करेंगे हम उसके ऊपर और पेशेंट से उसके कंफर्ट के बारे में पूछेंगे और सारे जो हमारा कैथेटराइजेशन और केयर का वो डॉक्यूमेंटेशन करेंगे उसको डॉक्यूमेंट करेंगे साइज ऑफ द कैथेटर पेशेंट का रिस्पॉन्स और any other recommendation from the patient and we'll provide him a health education for patient कि आगे फ्लूइड बैलेंस उसको कैसे रखना है स्टे हाइड्रेटेड एंड कैथेटर खींचना नहीं है और कोई भी प्रॉब्लम हो तो नर्स या डॉक्टर से आप संपर्क कर सकते हैं। थैंक यू।
Thank you so much, sir, for your presentation on clinical catheterization. As a pre-clinical approval committee member, I humbly call Dr. Anita Martin, ma'am, Vice Principal, Rohilkhand College of Nursing. Ma'am, please come and give your valuable comments on the procedure presented. Ma'am, please come. Sir, please come.
So this is a just common instruction I want to give for all of you. So, sir has done the procedure. Okay, good. That some of the things I wanted to include. The practice. There, how much you practice, definitely you won't make any mistake. So kindly practice more. And first of all, sir has not said about the privacy. So, okay, though you are doing the procedure, so you are demonstrating, maintain the privacy. And the gloves, kindly select appropriate size. So you won't be face any problem while wearing the gloves. And once you have done the gloves, so you have to maintain the sterile. Okay. So you should not touch the unsterile, and the person who is standing, you should not touch the sterile area. So kindly you maintain that. And the tray appropriate size you select. For the cleaning and for the sterile, kindly keep your big tray as well as kindly take your trolley. It is in the available. So you take from the NS ma'am, she will be providing. So kindly take a trolley and use the cut sheet sir has done later. Okay. And maintain one gauze. If you are taking one gauze, only you use it for only one stroke. Don't repeat it more and more. And you are having the number of gases also, it should be counted. How many stroke you have to use, that is pre-planned one. So you can do it accordingly and use the thumb forceps as ma'am said. So you pick from the thumb forceps and you use the artery forceps for the cleaning. Okay. And catheter cover, you don't need to remove it. From that catheter cover, you can collect the sample. Okay, there are some common instructions that to be followed by all.
With warm regards, I humbly welcome Mrs. Poonam Azad Ma'am, Nursing Superintendent, Rohilkhand Medical College and Hospital. And for further session, I would like to call Mrs. Anju Singh, Assistant Professor, Rohilkhand College of Nursing. Her topic is female catheterization procedure. She is PhD scholar, MSc and BSc nurse. She has more than 7 years of academic experience, published research articles, patentee holder, author of book in forensic science, research guide, and she has actively participated in national and international conferences. She has worked as practical examiner in nursing academic and clinical examinations for BSc and MSc nursing students and copy evaluator at Atal Bihari Vajpayee Medical University. Ma'am, please come.
Good morning, respected principal of Rohilkhand College of Nursing, principals of Peshnagar College of Nursing, all the faculty members. So, first of all, I thank the principal ma'am for providing this opportunity. So, which slide? So, without wasting our time, we move to the direct procedure. So, my topic is female catheterization, insertion, and care. The learning objectives are define urinary catheterizations, list down the principles, describe the types of catheters, enlist the purpose and the phases of procedure, and the nursing diagnosis and current trends. So start with introduction. Urinary catheterization involves inserting a sterile, flexible tube, that is catheter, through the urethra into the bladder to drain urine, either temporary, that is intermittent catheter, and for long term, that is indwelling or Foley's catheter. The purpose requires trial. The principles is so types of catheter is so my scenario is Mrs. Riya Sharma, a 52 years old female, was admitted to the medical ward with complaints of urinary retention, lower abdominal discomfort, and inability to pass urine for the last 10 hours. She is conscious, oriented, and anxious about the procedure. The physician has advised indwelling Foley's catheterization for continuous bladder drainage and monitoring of urine output. The vitals are stable. Next, come to the phases of procedure. The procedure is divided into three phases. Pre-procedure phase, in which we will prepare the articles and prepare the patient and environment. Next, intra-procedure phase, in which perform the urine catheterization procedure. And last phase is post-procedure phase, in which we will replace the articles and documents all the findings. So, start the procedure. First for clean phase and second is dry phase. Clean phase for one big bowl for medical holy water, water for the container area, immediate container, and we have furniture, temperature, so these are the articles for clean. First, check the picture order on the picture order. The articles and collect the pencil. Next, identify the patient by asking the patient name. This is Priya. फिर आपका कैटेगराइजेशन प्रोसीजर के लिए एडवाइस क्या कर रहा है, आप कॉलेज कैटेगराइजेशन रिसर्च कर रहा है, इसके लिए आप कोई भी डिस्कम्फर्ट या पेन हो आप बता सकते हैं। तो हमें आइडेंटिफाई करने के बाद पेशेंट को प्रोसीजर एक्सप्लेन करना है। देन पेशेंट को प्रोसीजर एक्सप्लेन करने के बाद हमें क्या है, प्राइवेसी मेंटेन करना है। कैटेगराइजेशन प्रोसीजर है, इसलिए हमें प्राइवेसी मेंटेन करनी है। नेक्स्ट पे इसके बाद हम क्या करेंगे, जो पेशेंट है एक्सप्लेन कर दिया, प्राइवेसी प्रोवाइड कर दिया, देन असिस्टेंट की हेल्प से हम पेशेंट में पोजीशन प्रोवाइड करेंगे फॉर गिवन कैटेगराइजेशन we will give the also recommend position. And also recommend position. Patient is a supine position in which these are flats and thighs are separated. हमेशा हमें पेशेंट को अपने क्लोजर में रखना है, जिससे हम पेशेंट का जो भी इंसर्शन प्रोसीजर कर रहे हैं वो इजीली हमें कर पाए। एंड हमेशा हमें पेशेंट के राइट साइड में खड़े होकर ही प्रोसीजर करना है, जिससे हम इजीली पेशेंट का कैटेगराइजेशन कर पाए। देन रिमूव करना है पेशेंट का ब्रेस्ट। I stop the separate condition. After leaving the position, perform hand washing. Clean the patient's perineal area with slippery body. And before starting the procedure, prepare the clean gloves bunch for them. And use the cotton sweat, cotton hospice or cotton pads. See the basic character. Then first dip in the plain water and clean the patient genital area. First we clean the outer area and then labia minora, and last scoop for binary meter. First labia minora and first each prostate or bottom side is for only one step. And discard it into kidney drain. Same, repeat the opposite side, clean the labia majora left side. Then next first is what bottom side used for cleaning the labia minora. Then labia. Then last bottom side will use the clean the clitoris. Then clean the inner uterus from top to the bottom and extending the anus area. So one step next step से हमें क्लीन करना है top to bottom area and extend to the anus area. It is called the bottom side. After providing the patient perineum care, then remove the clean ducts. This part is okay. Then next, we will perform again hand washing and clear the slide ducts. क्या करने के बाद हमें ओपन स्लाइड को ओपन करना है. White sheet, telescopic sheet, kidney clean, balls please, cotton sweat, then apply the telescopic sheet on the patient perineum. Next, also planning second stop. So again, Click from patient perineal area with bottom strap dip into antiseptic solution and spin with dissecting forceps. And अब हमारा क्लीन एरिया कौन सा एरिया है? मीटर्स का आउटर एरिया में होगा। मीटर्स वाला एरिया क्लीन है कि हमने पहले पेशेंट का पेरिनियल केयर प्रोवाइड कर चुके हैं, तो अभी हम क्लीन करेंगे इनसाइड टू आउटसाइड। बस वन स्ट्रोक से हम क्लीन करेंगे इंपोर्टेंस को और विद नॉन कम्युनिकेट हैंड से हम मीटर को सेपरेट करेंगे एंड देन इसको क्या है हम वन स्ट्रोक से क्लीन करेंगे मीटर्स वाले पार्ट। नेक्स्ट सेम लेबिया माइनोरम लास्ट पे लेबिया मेजोरम। Then insert the patient to the health system. Place the intake catheter in right place. Then for क्या assessment का इस्तेमाल होता है पता होना चाहिए आपको कहाँ रखना है। ओके चाहिए and to breathe then and insert the हमें प्रीवियस पेशेंट के लिए 3 to 5 सेंटीमीटर कैथेटर इंसर्ट करते हैं। राइट वाला पार्ट को हम यदि पेन फिक्स करते हैं तो ऑब्जर्व द यूनिट फ्लो। अगर यूनिट फ्लो या अनफोल्ड सही बैठ के साथ कनेक्ट करते हैं। बैठ के डेट से फ्लो करते हैं। सिक्योर करने से पहले थाइस पे सिक्योर करने से पहले हमें बैलेंस को इंस्टेट करना है। हम बैलेंस को इंस्टेट करते हैं जिससे कि हमारा जो कैथेटर है फिक्स हो जाए और उसका नाम आपका कंप्लीशन प्लेस द कैथेटर विद द adhesive tip on the patient eyes.
कैटेगराइजेशन केयर में चेंजेस है कि पहले हम एंटीसेप्टिक सॉल्यूशन से एंटीसेप्टिक सॉल्यूशन यूज करते थे बीटाडीन सॉल्यूशन, बट अब क्या है हम पेशेंट की जो क्लीन करते हैं बट पेशेंट को कैथेटर इंसर्ट है तब हम पेशेंट को नॉर्मल लाइन से क्लीन करेंगे, क्योंकि बीटाडीन सॉल्यूशन भी एक टाइप का एंटीसेप्टिक सॉल्यूशन है, इससे पेशेंट को और ज्यादा बर्निंग सेंसेशन हो सकती है। लेकिन नॉर्मल बिफोर जैसे पेशेंट को इंसर्शन कर रहे हैं तब हम बीटाडीन यूज करते हैं एज एंटीसेप्टिक सॉल्यूशन। अगर पेशेंट को कैथेटर केयर कर रहे हैं तब हम एंटीसेप्टिक सॉल्यूशन की क्या करेंगे, नॉर्मल स्लाइन का यूज करेंगे। थैंक Thank you, ma'am, for demonstrating urinary catheterization procedure so confidently. Now I call Dr. Anita, ma'am, Vice Principal, ma'am.
Kindly follow the body mechanics. The way you are standing and the holding the body mechanics you have to follow. The cheatal forceps, kindly keep the cheatal forceps down. You should not be in the up. And Macintosh and the draw sheet you have not placed. And you have to keep your patient nearby. You should not be in a distance. Keep it near. And the sterile techniques for all you have to practice it. And you have to see the fixing, but you have to see whether it is in a correct position. Then only you have to fix with the bag. After placing the bag, you should not check. And as ma'am has shown how with kindly practice, you no need to keep any assistant. So what ma'am has done yesterday in such a way you practice it. Clean, keep your clean tray and the sterility and everything should be ready. You are pre-prepared and you have to follow it. No need to keep any assistant because in the hospital we never get any assistant. Okay, otherwise ma'am has done.
For this session, I call Mrs. Chandraprabha Joshi ma'am, Assistant Professor, Rohilkhand College of Nursing, and she'll be teaching us assessing in endotracheal intubation. She is PhD scholar and MSc in BSc nurse. She has more than 6 years of academic and teaching experiences, published articles in various indexed national and international journals, research guide to BSc and MSc students. She is involved in NAC criteria section 6 activities, actively participated in workshops, conferences, seminars, and webinars, worked as practical examiner in nursing academic and clinical examinations, in BSc and MSc nursing students, copy evaluator at Atal Bihari Vajpayee Medical University. Ma'am, please come. This is an announcement for the delegates. This is an announcement for the delegates online that this is hands-on clinical skills training workshop. So we have feedback on the procedures going simultaneously. So after the procedure is presented, there is a feedback session which is going simultaneously. इसको complete करना पड़ेगा। There is an announcement for all the facilitators for tomorrow's session. Please arrange the required articles outside the hall so that pre-clinical committee members can assess your preparation for tomorrow. So it should be arranged outside the venue on today basis so that it can be visualized. And all the facilitators who are having their session tomorrow, they have to give their PPTs and introductory slide beforehand so that it can be arranged properly for better functionality.
ऑटोमेटिक लगा जैसे मैं दूसरे में होगी ऑटोमेटिक ठीक जैसे से चुका दो टिप लेस Shall we start? A very good afternoon to an all present over here, respected principal ma'am, vice principal ma'am, all the respected dignitaries of various colleges, and my dear students who are watching this workshop. First of all, I would like to thank the organizing committee to provide me this opportunity. So today I will be discussing the topic of assisting endotracheal intubation with a demonstration of it. So directly coming on the topic is assisting endotracheal intubation. As a nurse, it is very important to assist the physician while doing the endotracheal intubation as it is a sterile technique. So it is the prime responsibility of a nurse to make sure that aseptic technique should be maintained throughout the procedure. During the session, the students and the delegates will be able to introduce and define the procedure of assisting endotracheal intubation, principles and purposes of assisting ET tube insertion, indications and contraindication of ET tube insertion, articles used in ET tube insertion, procedures of assisting endotracheal intubation, post-procedural care and confirmation of the tube placement, special consideration, the role of nurse, advantage and the disadvantage of ET tube insertion, and the complication related to ET tube insertion. So before going directly to the topic, as we all know, the respiratory system consists of upper airway and the lower airway. The trachea serves as the passage into the lungs, and physiologically the air moves through the trachea to the lungs, and it delivers the oxygen into the blood, and the carbon dioxide is expelled. A clear airway is very essential for effective respiration. Any obstruction in that airway can lead to hypoxia and respiratory failure. So some condition like hypoxia and respiratory failure can lead to the breathing difficulty to the patient. So it is very important for the patient to maintain the artificial airway so that patient can take the ventilation through the assisted need. So what is intubation? Intubation is a medical procedure that is a medical process in which a healthcare provider inserts a breathing tube through the mouth or nose, then down to the windpipe or trachea. The tube keeps the trachea open so that air can go through. The tube can connect to the machine that delivers air oxygen with the pressure, that is mechanical ventilation. Whenever we have to provide the patient respiration who are not able to breathe spontaneously, then we have to attach the patient's ventilation to respiration to the mechanical ventilator. So it is very important to make sure ET tube insertion is important. Other names of the intubations are airway intubation is also known as endotracheal intubation, and tracheal intubation is also the other name. Definition: the endotracheal tube intubation, as I already told, it is a critical and life-saving procedure that is used to secure a patient's patent airway and ensure that adequate ventilation is going on. It involves inserting a thin flexible plastic tube into the trachea through the mouth or nose, typically under the direct visualization with the laryngoscope. Now, my procedure. As a nurse, it is very important to assist the physician, assist the doctor, or assist the healthcare personnel while they are inserting the endotracheal intubation. It refers to assisting a passing of a slender hollow tube into the trachea through the mouth and nose using the aseptic technique to facilitate the artificial ventilation or resuscitation. Throughout the procedure, there are some principles that a healthcare professional and a nurse should take care of. First one is managing the mechanical ventilation, right? Promoting patent airway clearance, because we are directly delivering the airway clearance and we are providing the respiration. So it is very important for the airway clearance. Reducing the anxiety and fear, because patient will be dealing with certain condition and there will be some fear and anxiety. It is very important to reduce it. Administer medication and pharmacological support. In some procedures, patient is needed to be उनको sedatives देने पड़ सकते हैं, तो इसलिए हमें medication administer करने हैं. Preventing respiratory injury risk, optimizing the cardiac function, facilitating the weaning process. What is weaning? Weaning is a process when we are gradually slowing down the assistance of the ventilator. Like if the patient is in ventilator, we cannot directly allow the patient to breathe spontaneously. So we will gradually reduce the support by changing in different modes. First ventilator and then and so many modes are there. So that process is called as weaning process. Then promoting communication and alternative methods of communication, because the patient will with the endotracheal tube will not be able to communicate properly. So we have to promote the communication and we have to educate the alternative communication methods to the patient. And initiative measures for the infection control. It is very important throughout the procedure that infection control measures should be taken care of. Promoting optimum nutrition balance. Now, the purposes, why it is important. First, the very basic important is we want to clear and open the airway. That is the main purpose. To secure the and promote patent airway, to prevent aspiration of the gastric content, to provide continuous ventilator assistance, to assist when the patient has difficulty in the breathing and patient is not able to breathe spontaneously, to ensure adequate oxygenation, to treat acute respiratory failure such as persistent hypoxemia, persistent rise in the PCO2 level. Now, the indication, when there are some conditions when it will be indicated that the patient needed endotracheal intubation, like inability to maintain the tone of the airway in conditions such as edema of the upper airway. Suppose there is edema or koi injury hai in the upper airway, so patient is not able to breathe spontaneously, then we have to provide the artificial ventilation. Trauma to the face, neck with oropharyngeal bleeding, inability to have spontaneous ventilation, clinically deteriorated conditions such as CNS depression, central nervous system agar depressed hoga patient ka, then also the patient will need the ET tube insertion. Then neuromuscular diseases, septic shock, stab wound in the neck with hematoma, intracranial hemorrhage with the changes in the mental status, cervical spine fracture, unconscious patient with the Glasgow Coma scale 8 or less, because if the Glasgow Coma scale is low, then the patient responsiveness will be reduced. So in that case, patient can also be needed the endotracheal intubation. Respiratory arrest, that is a very main indication of this condition. General anesthesia for surgical operations. In many surgical procedures, when we want our patient to take the breathing and the patient will be remain unconscious during the surgical procedure, in that case, sometimes this procedure is also done. Then airway obstruction. If there is any airway obstruction like tumor, any trauma, any injury, any swelling, so in that case also it is needed. Next one is contraindication. What are the conditions when we cannot use the endotracheal intubation, such as severe facial or airway trauma? If there is airway trauma or distorted anatomy, it will not be able to insert properly so it will be a little bit risky and difficult. Obstructive lesion in the upper airway, such as any tumor is there, any lesion in the upper airway is there, so it will be contraindicated. Unstable cervical spine injury, because there will be some muscular movements, abnormal muscular movements will be there, so it will be difficult to put that tube. Then severe laryngeal condition जैसे कि infection, edema, fractures can complicate the insertion. Limited mouth opening in case of burn, such as contractures are there, burn conditions are there, and the patient and some congenital abnormalities are there. Patient will not be able to open the mouth. So in that case also, and the patient refusal. If patient and the relatives are having alternative options of the endotracheal intubation, yeah, for artificial ventilation, they can deny or patient refusal. In that case, we will not do. Now as the next case scenario, firstly, I will just explain all the procedure here because there are some important points that I have shown through the means of some images. And then I will do it in the procedure form. There is a case scenario that a 45-year-old male is there with he has admitted in the hospital emergency department due to road traffic accident and unconscious with the GCS is 6:15 and SpO2 is 82. The doctor decided for the immediate endotracheal intubation. As nurse, we have to quickly prepare the ET tube, laryngoscope, suction and ambubag and position the patient the pre-oxygenation. Drug intubation, they hand over the instruments, apply cricoid pressures instructed and monitor SpO2. Now, before going to the procedure, there are some articles that we will be needing. First, very important, endotracheal tube, and there are different sizes of endotracheal tube. And 7.5 mm is universally accepted size for an unknown victim. But for usually for the man, 8 mm tube may be appropriate, and females के लिए 7 mm tube may be appropriate. Then astilit, a wire that is a hardened एक हार्डन ट्यूब होता है जो हमें एंडोट्रैकियल ट्यूब को करेक्ट प्लेसमेंट के लिए हेल्प करता है ताकि जो एंडोट्रैकियल ट्यूब बिकॉज इट इज अ थिन प्लास्टिक ट्यूब उसकी स्टिफनिंग के लिए वी आर यूजिंग द स्टिलेट वायर एंड बूजी दिस बोथ आर फॉर द स्टिफनिंग ऑफ द एंडोट्रैकियल ट्यूब ड्यूरिंग द पैसेजवे laryngoscope with appropriate straight and curved blades with batteries to visualize the area. Magle forceps to prevent the biting of the tube, and if there is any dentures, any oral foreign particle is there in the mouth, to remove out this, we can use this Magle forceps. Then oral airway, suction catheter to remove any secretions from the oral cavity, suction apparatus to apply the suction, oxygen source and tubing to provide oxygen support, disposable syringe 10 ml, xylocaine jelly to lubricate the ET tube, towel to support the neck for proper maintaining the position of the patient, sterile gloves and mask, ammo bag with mask, stethoscope, cotton tape or dynaplast to the scissors, rolled towels and medication that will be given by the anesthetist. So we have to help also the anesthetist so that to sedate the patient. These are some diagrams that we will be showing in the procedures as well. First one is your ET tube. It looks like this. ये एक general 7 आपका mm की एक ET tube है. Then next one is different sizes of the blades of laryngoscope. There is a bulb that is for the visualization of the vocal cords. Then हमारा bag valve mask. Then Magle forceps, I already told you कि हमारा कोई भी foreign material है या फिर कुछ भी dentures है उनको remove out करने के लिए. Then this packet of blue color that is bougie, that is for the stiffening of the ET tube. Then syringe and tape and oral or nasal airway. Now, a quick guide for ensuring essential articles that we cannot skip any articles in the tray. So there is a quick guide, SOAPME, that is S reflects your suction. All the articles related to suction that should be there. Oxygenation and breathing marks. Okay. A reflects airway, endotracheal tube. P refers to positioning and personnel. Position, it is very important for maintaining the position of the neck and the personnel, that adequate number of the personnel should be available at the bedside. M means medication and monitoring. Medications, anesthetic should be ready if needed, and the monitoring, continuous monitoring of the cardiac signs should be done throughout the procedure. And equipment, that is functional ventilator, should already be in the functioning condition near the patient side. Okay, now before the procedure, some of the points are there which should be ensured by the nurse. Ensure the patient should be NPO unless emergency. If there is any emergency, then we can use RT tube. We can also aspirate and empty the bowel. Then ensure suction is working appropriately and attach appropriate size of suction tube. Wash hand and wear personal protective equipment. We have to pre-oxygenate the patient because for some time we will not provide any, patient will be in the sedators, patient will not be able to breathe proper by its own. So for some time, for 1 to 2 minutes, we have to hyperoxygenate the patient with 100% of oxygen for 3 to 5 minutes so that oxygen की कमी नहीं होनी चाहिए patient में. Then we have to check the vital signs throughout the procedure, SpO2 and the readiness of the suction. Position the sniffing position for optimum airway alignment, that as you can see in the image right down there. The sniffing position, that is a flat position, aligns the pharyngeal and the laryngeal axis in the optimum position for the intubation and airway management. That should be in the flat position so that we can visualize easily the opened airway. Then that position is called as your sniffing position. Ensure IV access for the medication. Maintain aseptic technique throughout the procedure. Now, the procedure I will also do it, but before that I will explain the procedure to the conscious patient to reduce the anxiety. If conscious, then take the consent from the relative or patient. Assemble and prepare all the equipments needed in reach. Assemble laryngoscope to ensure that light all the equipments beside the patient bedside should be in the working condition. ये हमें पहले से ensure करना है that everything is in the working condition. Place the ET tube in a sterile field and inflate the cup. Just 1 or 2.
Or the article website. There will be some area where we have to on the article. It will be considered. If we use this area, and sterile. And these are the articles that I will be needing for this. Okay. I will be needing about like healthy person होना चाहिए, but it is not an individual task. I can do item. There will be some position. Will be acting as a thinker, and I will be the third. And I am acting as a thinker, and that whole associate person shall be there. Firstly, you have to explain the procedure to the patient that you are going to do. If the consultation is there, we have to explain the procedure. Mr. Ram is the patient who is certified for the who is unconscious, and I have already explained the procedure to the relative of the patient that you are going to do is going to easy information because the patient is unconscious and you are certified. For starting the procedure, you have to arrange the basic website. Firstly, physician का जो रोल है कंसल्टेंट के टाइम पर दिखाई दे बाकी सर सारे काम जो है अदर के बारे में करते हैं हमें भी सर ओनली बेटर Firstly, when we operated, I told you sniffing position to be maintained. There will be a patient who from a sniffing position maintained earlier. Ustani, her medical technique है that should be the strong position. And we have applied our nose towel. Okay, so that we can ensure delivery better airway and there will be the method that is motivating the patient continuously from the in the article, in the moving described from in the purpose of down and the question in the person that is not towel. These all are the articles which are sterile, but those are in the packaging. So I can make a sterile area, and my assistant is over all the sterile area. So I will be using the facility of the fish sizes. So in the fish, I will be using seven cycles. Sterile glass, 10 ml, 10 jelly, stethoscope for the checking of the closement of you, section container, younger. Younger is for functioning the oral cavity, the mask. These are the articles, and some articles are there in the sterile dressing. In that we have usually sterile metal vessel, individually towel, and we have in some water. In the my assistant cannot touch the area when I will be doing hand washing and wearing the gloves. I can touch all the right fixing from area. Hello? Then firstly you have to wash your hand. After the hand washing, I will come here and I'm sitting in the glass. Make sure my techniques are ready. You can touch, but you cannot touch the sides of the glass. And then the handle, so I can touch the inner part of the steering wheel. I am opening it and looking at the area title, and now the assistant can tell every sliding in this section. And that's Every veggie with the oils riding technique and downing and planting and mass. मतलब मैं आपको करूँगा I don't stand to the side. Video of 7 TV just okay. As you can see here, my assistant cannot touch the salivary thing. But time I will finish. Perfect. And the bag is not should be ready, but we can when we will do the station and when we do the vaccination, you have to pre-vaccinate with 100% of oxygenation, but 30 to 5%, 3 to 5%. I will hand over. Then I will put to the physician and substrate side of reduce weighting. So there is a manual that is functionally cellular in that have to apply the pressure over the thyroid and the 3.4 so that हमारा head has a success and we will apply some pressure so that the physician can see the effect of the fraction. Then and we have to secure this to an envelope here. We can check the key placements by different methods, but which I am using is the test balls है that should be दोनों साइड bilaterally दोनों साइड क्या होना चाहिए सेम माउंट पे ये होगी there should not be time here, but it will be something very fast.
Then back. See the chest wall line and it is chest wall bilaterally equally I think it is very lungs. That it is the ventilator. And if we want diagonal, put another diagonal, then we can fix it and it has after that, we have to fix the diagonal part. Have to fix. Only for the select maneuver, this is the select maneuver that we need to give 3-point pressure. In first, that is select maneuver representing in the first image, that we have to put the pressure in the 3/4 thyroid plate and it's the thyroid cartilage. In that phase, we have to apply some pressure. और बहुत ज्यादा प्रेशर नहीं देना है because in some cases it can be fracture as well. अगर ज्यादा हम लोग प्रेशर देंगे but adequate हम लोगों को प्रेशर देना है so that when we will be extending the airway, then जो scope से वो open करेगा position तो that will be easily visualized if we will give this Selix maneuver. That is the image where the personnel is giving the Selix maneuver while the physician is inserting the ED. As you can see here in the image, we have to apply the pressure in the thyroid area. Post
procedural care, nursing priorities in the mechanical ventilation. We will always, after the procedure, we will place the patient in the lateral position. We have to assess the respiratory status, including the lung sound and Q2 and ECO2. Watch the chest movement, ET thinking, obstruction, the blood and secretions. We have to suction it and leakage of the tube cup, overinflation of the cup, detect and respond to complications, tube dislodgement, pneumothorax obstruction, prevent ventilator-related issues like ventilator-induced pneumonia and lung injury, collaborate with the team to optimize the process of the weaning, extubation readiness. Confirmation of the tube placement, I already told you कि एक तो हम लोग क्या करते हैं दोनों साइड से respiratory wall chest walls को देखते हैं दोनों साइड bilateral inflation के लिए. Other methods are also there. Observe the chest rise with the bilateral red sounds. Auscultate lungs epigastrium with stethoscope. There will be gurgling sounds of air. Monitor EtCO2 capnography for the CO2 detection. Check SpO2 improvement. अभी patient का AP2 हमारा experience है, then it will be improved. Then final confirmation will be done by the chest X-ray for the final verification and the secure tape, secure the tube, the tape and tube contacts. Special consideration after the procedure is assisting with the endotracheal intubation requires careful preparation and adherence to best practices to ensure patient safety. Some of the special considerations ensure all the necessary equipments are available, including the laryngoscope, ET tube, suction devices, band wall mask. Verify the ET tube size based on patient's age and condition. Check the cup integrity by inflating and deflating it before use. Be prepared with the alternative airway devices such as supraglottic plates if intubation is challenging. Provide 100% oxygenation beforehand. Monitor pulse oximetry throughout the procedure to check the desaturation early. Hand the correct size ET tube to provide to the provider promptly. Avoid and apply cricoid pressure that I already told you, Felix maneuver to reduce the aspiration risk. Ensure suction is ready to clear the secretions or blood obstructing the airway. Confirm tube placing using auscultation, capnography, and chest X-ray. Secure the tube with tube holder or tape. Monitor the complications such as laryngeal itching. Nursing care after the intubation, we have to maintain the patent airway, continuous monitoring of the oxygen, provide humidified oxygen to prevent mucosal and dryness. There should be a humidifier in the oxygen source. Regular suctioning, clear the secretions, prevent the infection, hand hygiene, oral care, assess sedation, comfort, and communication needs of the patient. Educate the family about the procedure and the patient status. Prepare role of nurse, prepare the equipment and patient before the intubation, assist the patient during the procedure and keep correct tube and suction ready. Monitor patient's vital signs, oxygenation continuously, confirm tube placement and secure it properly. Provides ongoing care such as suctioning, oral hygiene, infection prevention, educate patient family and support communications, collaborate with the team, the ventilator management and weaning. What are the advantages of the tube insertion? First, if the patient is not able to breathe spontaneously, then we can provide rapid airway control in the case of emergencies. We can prevent aspiration and can support the ventilation, allow administration of oxygen, anesthesia, and medication. It facilitates suctioning of the secretions, essential for major surgeries and critical care. What are the disadvantages? Requires skill and equipment not always feasible in the clinic setting. Risk of trauma, infections, complications, prevent patient discomfort and the need for the sedation. Prolonged intubation may cause airway injury. Dependency on the mechanical ventilation can be there. Some of the complications are there. Trauma, like if during the insertion any trauma is there, dental injuries, laryngeal bleeding, edema is there, then there can be trauma. Hypoxia and the bradycardia during the attempts. Because if the attempt is taking time due to any difficulty, any obstruction, then it can lead to hypoxia and the bradycardia. Aspiration of the gastric content, tube malposition or accidental extubation, ventilator-associated pneumonia, tracheal stenosis with the prolonged intubation can be there, pulmonary infections and scarring, and if this can be there. Now, I summarize my topic. Endotracheal tube, एक life-saving procedure है to secure the airway and support ventilation.
Proper preparation skill and teamwork are very essential for the success. Nurses play a very important role in assessing, monitoring, and preventing the complications. The ultimate goal of this procedure is to ensure patient safety, effective oxygenation, and readiness for the extubation. Conclusion: endotracheal tube, the vital life-saving intervention that ensures adequate airway vacancy, support ventilation, and prevents aspiration to critically ill patients. Successful intubation requires through preparation, skill, execution, and repeated monitoring to minimize risk and complication that is play an important role in the process. Throughout the process, from assisting during the procedure, confirmation of the tube placement, and to provide ongoing care to maintain the airway safety and patient comfort. Ultimately, effective teamwork and adherence to the best practices make intubation not only the technical procedure but also a cornerstone of the critical nursing care. Thanks. These are some references that from that I have conveyed. Thank you.
For feedback of this procedure, I invite Dr. Rita B. Ma'am. Ma'am, please come.
I appreciate the Chandrababu ma'am. She has taken the good effort for arranging all the things. So this is the feedback. It's not to demotivate anyone, just to improve your practice. And mainly, this is the common information for all of you. Do concentrate on the practical thing much more, procedure and the documentation. And whenever you are doing the procedure, just you follow the NHS guideline and in our hospital policy, what we are following that. That will be good. We are following that. And the ETTB session that may be the plan or emergency. So we have to do it accordingly and we have to arrange it. Whether it's a plan or emergency conditions, in our hospital we are keeping 3 nurses and 1 and 2 and 3. 1 for assisting, 1 for circulating, 1 to check the menu. There are 3 nurses we have to keep. And the screening also should be practiced. And the physician, this is the physician is doing, but the nurse, there should be a coordination between the nurse and the physician. So what the physician wanted the nurse has to do, and the nurse also should be, she has to keep everything in a ready process. That should be in a coordination, and you have to give the ET this everything in a different size. So we cannot fix when the patient is it's not working, we have to keep it in another one ready. So we cannot run for that. Now all the sizes 6, 6.5 up to 8, and for the children we have to keep it ready. And we have to check the instrument whether it is working or not. And this laryngoscope also. And one person is that the physician or nurse should check on the monitor whether all the parameters in here correct one is going, the saturation is going down. So one person should look on the monitor also. There's a thing.
Thank you, ma'am, for all the efforts and hard work we bestowed in the demonstration part. Before moving on to the next session, can we have a huge round of applause for dear students? Can we have a round of applause for strong, very strong and big hands? So moving on to the next session, I would like to call Mrs. Anupriya S. Lal, ma'am, Assistant Professor, Keshwara College of Nursing. She has a total experience more than 10 years, PhD scholar, MSc nurse, and she has work experience of nursing tutor with a massive teaching years of experience, paper setter, evaluator. She is a member of TNAI, participated in TOVs and in simulation center, and participated in many national and international conferences. Ma'am, please come.
A very good afternoon, one and all present respected principal ma'am, vice principal ma'am of Rohilkhand College and School of Nursing, and principal ma'am and vice principal ma'am of Keshlata College and School of Nursing. Myself, Anupriya Aslal, assistant professor, Keshlata College and School of Nursing, and today my topic is tracheostomy care. So first of all, what is tracheostomy? So a tracheostomy is an artificial opening in the neck into the windpipe, that is trachea. This opening is called a stoma and it allows air to go in and out of the lungs. A small tube, that is tracheostomy tube, is inserted through this opening. Breathing occurs through this tube. Next, what is the introduction? So tracheostomy care involves daily cleaning of the stoma. So we have to clean daily and stoma and inner cannula and changing ties to prevent infection and blockages. So I have to define the tracheostomy care. Tracheostomy care including changing a tracheostomy inner tube, that is inner cannula and obturator, and cleaning tracheostomy, stoma site and cleaning present around the site. So there are some principles for tracheostomy care. The first principle is to maintain airway patency. So we have to maintain airway patency of the patient through tracheostomy tube. For this, we have to take care of free from mucus and secretion of tracheostomy tube, performing suctioning when needed, and ensure that we have dehumidified patient and encourage patient to cupping. Next principle is use aseptic technique. So before doing any procedure, especially this type of procedure, so we have to use aseptic technique. For this, we can use our hands before and after, use sterile equipment and suctioning and dressing changes, clean stoma site regularly to reduce infection risk. Next is proper tube care. Inspect the tracheostomy tube for blockage or displacement. So we have to check every time of the tracheostomy tube for their blockage and displacement. We have to clean and prepare the inner cannula as prescribed. We have to ensure that ties or strap of the tracheostomy, that is not too tight and not too loose. At least 2 finger loose, so patient can move their neck. Next one is stomach care. So we have to care routinely at least once a day. So clean the skin around the stoma with normal saline or prescribed solution. It is prescribed at the hospital and according to hospital policy. So which solution we have to use for the cleaning of the stoma. Keep the area dry and observe for redness, swelling, discharge, and foul odor. Change dressing when wet or soiled. Next principle is to prevent infection. So monitor temperature and respiratory status. We have to monitor all the parameters of the patient and observe the secretion, color, amount, and odor. We have to maintain clean equipment and environment. Next principle is to ensure adequate oxygenation. So we know that tracheostomy will be done for the maintain airway patency. So we have to ensure that oxygenation, adequate oxygenation should be there. For this, we have to monitor the respiratory rate and oxygen saturation and breathing pattern of the patient. If patient have breathing difficulty or if patient saturation is down, so we can provide oxygen therapy and we can put on the ventilator as doctor described. Watch for sign of respiratory distress such as cyanosis, restlessness, or noisy breathing. Next principle is to promote communications. So as we know, if patient having tracheostomy tube, so patient cannot be able to speak. So we can assist the patient with some communication method such as writing pads, speaking valve, and gesture or communication devices. Next principle is to maintain nutrition and hydration. So encourage patient to take adequate fluids to help thin the secretions and assist solid ability to prevent aspiration. Next principle is to prepare for emergency. For every emergency, we have to provide all the equipment at bedside, especially the obturator, spare tracheostomy tube, same size and one smaller, and suction equipment and oxygen sources. We prepare for accidental decannulation or blockage. Next one is patient and family education. So some patients having tracheostomy tube for a long time. For this, we have to educate the patient as well the patient attendants. So teach cleaning and sectioning technique to the patient and to the family members and explain the sign of complications such as difficulty in breathing, bleeding, infection, tube displacement. Teach emergency action and follow-up cares. Now comes to the next thing, that is purposes of the tracheostomy tube. So our purpose is to maintain patent airway, to enable the removal of tracheobronchial secretion, to permit long-term positive pressure ventilation, to improve patient comfort, to decrease the work of breathing and increase volume of air entering the lungs, to prevent infection at the tracheostomy site, to facilitate healing and prevent skin exudation around tracheostomy care, and to assist condition of stomach. And what are the indications for the tracheostomy? So first, if patient having obstruction in mouth or throat, so we can go for the tracheostomy. If patient having any kind of breathing difficulty and edema, injury, or pulmonary condition, so we can also go for the tracheostomy. And if patient having airway construction following tracheal or laryngeal surgery, if patient having any kind of laryngeal or radial surgery, so we can go for the tracheal tracheostomy. Airway protection from secretion or food because of swallowing problems, and airway protection after head and neck surgery, long-term need for ventilator support. If patient having on ventilator, so we can do the tracheostomy because it is more safer than the endotracheal tube. Now, next is contraindication for the tracheostomy care. So first is suspected CSF leak. If patient having bacillus skull fracture or raised intracranial pressure, so we don't go for the tracheostomy. And if patient having tracheo-esophageal fistula, if there is any abnormality in the tracheal, so we cannot go for the tracheostomy. And if patient having any type of cancer in upper GI or respiratory tract, and if patient having esophageal or high GI surgery, so we cannot go for the tracheostomy. Now, some nursing process according to Nanda. So first is assessment. So in assessment, presence of tracheostomy tube, respiratory rate, breath sound, saturation, amount, color, consistency of secretion, sign of infection, redness, swelling, fever, airway frequency, and breathing effort. We have to assess all of these for assessment. Next, how to diagnose. So ineffective airway clearance related to presence of tracheostomy secretions, risk for infection related to invasive airway device, impaired gas exchange related to altered airway, risk for aspiration. Next one is goals and plannings. So first we have to maintain the patient airway, prevent infection at tracheostomy site, improve oxygenation and ventilation, ensure patient comfort and safety. Implementation, maintain sterile tracheostomy care techniques, perform suctioning as needed, provide provide humidification, humidified oxygen, clean stoma and change dressing, monitor vital signs and saturation, ensure emergency tracheostomy equipment is available. Next is evaluation. So airway remains clear and patent. We have to evaluate after care, no sign of infection, stable oxygen saturation, reduce secretions and improve breathing. Some other clinical guidance of tracheostomy care. So it is same as purposes, routine tracheostomy care, humidification, suctioning, cup pressure management, emergency management, infection prevention, and decannulization here. Here we have the parts of the tracheostomy tube. So we can see here, it is a cupped tracheostomy tube. So we can see tape attachment and flanges, shaft, cup, distal tip, one-way valve, pilot balloon, cup line, and 15 mm connector. So these are the parts of the cup tracheostomy tube. It is a disposable cup tracheostomy tube. Next, I will show the types of tracheostomy tube. There are various types of tracheostomy tube, which is we are using in clinical side. So there is a cupped tracheostomy tube. It is mainly used for patients who are on the ventilator. Next, it is a uncupped tracheostomy tube, and it is mainly used for the pediatric patients and adult also, but there is no any sealed. And it is a adjustable flange tracheostomy tube. So we can see here there is a flange and it is adjustable. We can use it and we can adjust the length of the tube according to our needs. Next is fenestrated tracheostomy tube. So it is a fenestrated tube which is used for the patient who is going to be weaned. So we can use this kind of tube for weaning patient. And it is a Shelley tracheostomy tube. Shelley is just only the brand name which is used. It is not any type, but it is only the name Shelley. And next one is double cannula tracheostomy tube. So here we use double cannula, outer cannula and inner cannula. So when we are cleaning and when we are going to give the care of the patient, we have to give the whole care and we have to clean the inner cannula as well. Next one is pediatric and neonates tracheostomy tube, which is more flexible and small than others. Last one is tracheostomy tube with speaking valves. So it is a type of tracheostomy tube which is with speaking valve. So those who are not able to speak, it can use for patient, those who want to speak. So it is speaking by directly airflow through the vocal cord. So now comes to procedure. Here Is there audible? So here our patient is private and there also supplies like kits are ready, such as structural mount and all the equipments and all the supplies are have already maintained and all the furniture. For that, we are now procedure of pyramidal pattern. We have three places. Place or place each other. So I'm not going to mediate the platform or already the platforms. So for as we have the treatment is performance is and terminating the case and treatment we have the treatment of the article and treatment of the stress. So first is related of the patient. So let's see. Firstly, I identify the patient by asking his or her name, but patient is not able to speak. So I check I check his pen of the patient. My patient is Mr. Ramesh, and he had a surgery of laryngeal cancer, and he underwent two tracheostomy care 3 days before, and doctor advised to take daily tracheostomy care. So I identify the patient by checking the wristband in the hand. So he is my patient, and his name is Mr. Ramesh. So I explained the procedure to the patient. So Mr. Ramesh, आप कैसे हैं? मैं आज आपकी ट्रिकोस्टमी ट्यूब जो आपके नेक में है इसकी केयर करने जा रही हूँ. अगर आपको किसी तरह की कोई परेशानी होती है तो आप अपना हाथ उठा सकते हैं. So I explained procedure to the patient and I have already checked that of the doctor ordered daily care of the tracheostomy. Then at the same time, I assess the tracheostomy site that there is no any bleeding, there is no any swelling and no sign of any infection. Before that, I am not going to do the suctioning because suctioning part will be do by the another faculty. So I just do the care of the tracheostomy. Then I prepare the article next phase. So here I have this tray. In this I have steroid also, and in this I have hydrogen peroxide for cleaning the tracheostomy inner cannula. I have another NS to clean the inner cannula. I have this kidney tray with cut the waste. I just put here one tracheostomy tube, just showing it is a disposable cup tracheostomy tube. I have mask to prevent infection. I have 2 pairs of sterile gloves, and in sterile tray I have contained 3 bowls, and I have contained cotton applicators. I have contained brush to clean the inner cannula. I have contained a sterile towel, and I have contained dressing and wash basin to clean the tracheostomy. Now I'm going to start my procedure. So performing phase. Firstly, I remove all the ornaments. So I have already removed rings and other things. Firstly, I have to do the hand washing with proper 7 steps. and wearing only one glove in my dominant hand. I am right-handed, so I am wearing only one glove. So my right hand is totally sterile, so I'm not going to touch any of these things. So from my left hand, I'm going to open my sterile tray by using shuttle faucet. And this field is considered as a sterile field. And my right hand is sterile, so I open my sterile tray and place it here. I have 3 bowls, 1, 2, or 3. So I pour. Firstly, I pour hydrogen peroxide in one bowl. And I have poured NS, sterile NS, in second and third bowl. Make sure that there is not any spill. So here I'm using my right hand, which is I'm already considered as sterile, and put sterile towel or any sheet in over the chest of the patient. Now I'm wearing my next glove. Firstly, I remove inner cannula from the tracheostomy tube. So I unlock the inner cannula and remove it and put it into the hydrogen peroxide solution. And then I remove old dressings from the tracheostomy site and assess it for any bleeding, any sign of infection, but my patient do not have any secretions and any type of bleeding. So then I remove it and discard it yellow bin. Next, I'm going to again do the hand rub. And wear next pair of sterile gloves. So firstly, I clean the inner cannula of the tracheostomy tube. So I have this brush, but usually this brush is not used for cleaning. There is a long and thin brush for you to clean the inner canula, but I am using this. So firstly, I clean some patches of the inner cannula and shaft of the cannula and cut it this, and again I can use this cotton applicator and can same this and clean it with and discard it. Then and applicator and clean the phalanges of the tracheostomy tube. Firstly, I am clean outer surface of the faceplate of the tracheostomy tube and then inner side of the stoma. So I cleaned it nicely. Now I put dressing on the tracheostomy tube. So here I have this dressing. It is sterile and it is anchored in between. So I took it into the tracheostomy site. Now I change the tracheostomy style, which is already I have. So we are doing it alone. If we have one person, so I can say hold this tracheostomy tube, but I am doing it alone. So firstly, I have to So I place human, then I remove old tie by holding and tie it well. Some hospital have another kind of tie and collar band. To make sure there is at least 2 finger loop, not too tight and not too loose. And cut extra edges. So here my patient is comfortable. I remove the sheet and discard it. So here my procedure done. But after that, I have to check the patient for respiration and all the monitoring. And then I discard the gloves. Fourth, procedural and aftercare steps. So provide comfortable position to the patient. Remove face shield or mask and goggles. Remove gloves and discard. Replace the articles. Perform hand washing. Reassess patient's respiratory status, including respiration rate, effort, oxygen saturation, and sound. And documentation and evaluation. We document about the baseline respiratory conditions such as rate, rhythm, effort, stomach conditions such as appearance, erythema, swelling, for secretion, example, amount, color, thickness, and order, patient tolerance, pain or vital signs, type of care delivery, cannula change, dressing change, we have to document in our file. It's all about my procedure. Thank you so much for listening. For feedback, I call Dr. Anita Godley, ma'am. Thank you, sir. Very nicely presented, all the contents, and especially the procedure. Okay. Very nice, very good. Yeah. बस एक पॉइंट बोलना मांगूंगी, सिर्फ वन। थोड़ा सा हमको अपने बॉडी मैकेनिक्स का ध्यान करना चाहिए, इसी के लिए नहीं, सभी के लिए। और मैम वो भी एक ऐड करते हैं कि डॉक्टर ने जो पार्ट्स में कर देते हैं ना, पार्ट में इतना नहीं जाना पड़ता बार-बार। थोड़ा सा अपना नर्सेस को एक प्रॉब्लम ये होती है कि उनको बैक पेन हो जाता है ना, तो अपनी बैक उनको स्ट्रेट करना है और पेशेंट को थोड़ा अपने और पैनिक कराइए।
एक पॉइंट और ऐड करके जो डॉक्यूमेंटेशन है इस सिनेरियो का अकॉर्डिंग फिर करके बताना है वो मतलब ये करना चाहिए नहीं बस फिर करना है सभी
एक पॉइंट और है, डॉक्यूमेंटेशन हमको अपना अकॉर्डिंग टू केस सिनेरियो आपको करके बताना। थैंक यू।
Thank you, Anupriya ma'am, for your deep insight into the topic of tracheostomy care demonstration. Now, we further move on to a series of procedures as intramuscular subcutaneous injection, IV canalization, and injection. For this demonstration, I call Mr. Shifa Singh ma'am, Assistant Professor, Rohilkhand College of Nursing. She has a marvelous experience of 16 plus years, Masters and BSc nurse. She has national award. She's a national award winner for Best Young Faculty 2025, Dynamic Women Health Educationist Award, Women of Impact Award. She has two patentee and name, both publication of neonatology nursing, research and academic work, several publications as national and international publication. She has been a research guide, examiner, paper setter, evaluator, and university observer at EMU and EIU. She has attended and being a facilitator, many workshop and conference results. Ma'am, thank you so much, ma'am.
Good afternoon, everyone, and thank you for giving me this opportunity. So, my topic today, I'm going to present intramuscular, subcutaneous, intravenous cannulation and injection. So, here are the learning objectives. At the end of the session, learners will be able to define intramuscular, subcutaneous, IV cannulation and injection. Explain indication, contraindication, principles and purposes, and also identify equipment required. Demonstrate correct procedure steps, apply infection prevention and patient safety guidelines, manage complication, perform documentation and evaluation, and also demonstrate skill through OSCE scenario. So this is the introduction of the injection, and injection is the medical act of introducing a liquid substance such as medication, vaccine or nutrients directly into the person's body tissue or blood streams using a syringe and a hollow needle. So here are the purposes of injection: to get a rapid and systemic effect of the drug, to provide a needle effect, assure the total dose will be administered and the same will be absorbed for the systemic action of the drug. And this is a very important point. कि we have to assure कि जो dose हम administer कर रहे हैं at the same time the same dose absorb भी होनी चाहिए. Provides the only means of administration for medication that cannot be given orally. To restore blood volume by replacing the fluid, for example, in shock conditions. So here are the 10 rights of medication, the right patient. We have to check the right patient by his or her identity, like his or her name, the identifier from the hospital number, the unique ID given by the hospital or institute. We have to check the patient, right drug, which is prescribed by the doctor only, and right dose, like 1 ml, 2 ml, the right dose, right route. Either the doctor prescribed the IM or IV, right time and frequency. The right time we have to put it in the file, the right time also and the frequency also. Right response. The patient जो है उसको वो response उसको मिला after the getting the medication. The right documentation, which is very important in our nurse's life. Right documentation and right to refuse. Patient has all the right to refuse, and we have to respect his or her refusal. The right education, we have to educate the patient, which kind of drug you have to administer to the patient, and the right reason. Why you given that particular drug to the patient, you have the right reason to tell the patient. There are the types of injection: intramuscular, subcutaneous, intravenous, and intradermal. And I'm going to tell you about the intramuscular and subcutaneous. Different injection angles: intramuscular injection given at 90 degree, and subcutaneous at 45 degree, and intradermal subcutaneous at 45 and 90 degree also. If the patient is fatty and have a good fatty tissue, you can also give in the 90 degree. Intradermal 15 to 20 degree. Types of syringes: there are different types of syringes: 1 ml, 2 ml, 3 ml, 5 ml, 10 ml, 12 ml, 20 ml, 50 ml, 60 or 70 ml. There are needle gauges for the injection size chart. We have the 14 gauge, 15 gauge, 16, 18, 20, 21, 22, 23, 25, and 27 gauge of different kind of needles. The parts of the syringe and the needles. In the syringe, we have the plunger or the barrel, cap in the needle, cap, and in needle, there's a needle, needle hub, needle, and the human shaft and bevel. और जब भी हम patient को administer करेंगे any kind of injection, we have to make sure the bevel part of the needle is like up, मतलब वो ऊपर होना चाहिए, not involved. So here I'm starting the iron injection. So this is the definition of iron injection: a form of parenteral administration of medication where a drug is injected into deep muscles tissue. The sites for the injection: deltoid, vastus tracis or rectus femoris, ventrogluteal and the dorsogluteal. Now, dorsogluteal nowadays it's not recommended. So these are the sites for the iron injection. So here are the purposes. The rapid absorption of the medication. Why we given the iron injection? Just because of the rapid absorption of the medication, administration of vaccine, antibiotics, hormonal preparation. If the patient is going under the hormonal therapy, we can also give the iron and analgesic also. So here are the principles. The first, maintain aseptic technique, select correct site, choose correct needle size, avoid nerves and blood vessels, and follow the medication right. Indication, moderate volume medication, vaccination, emergency medication, and drugs irritating to subcutaneous tissue. There are some drugs we have who irritate the subcutaneous tissue. That's why we given it to the iron form. Here the contraindication, infected at site. If there is a site which having an infection, we contraindicate that site. Bleeding, if the patient is having the bleeding disorder, the muscle atrophy, shock, and any patient is allergic to the particular medication. So this is the diagnosis, the assessment. The subjective data, I have severe pain and which I as a nurse observe the facial grimacing, darting behavior, restlessness, and difficulty in movement. The nursing diagnosis, we have the acute pain related to the musculoskeletal inflammation and tissue injuries as evidenced by verbalization of pain score 10 on 8, facial grimacing, darting behavior, and restlessness. So we have the goal. Report the patient with reduction in pain from 8/10 to 3/10 or within a 60 or 30 or 60 minutes after administration of iron diclofenac. Nursing intervention, assess pain using pain scale, monitors vital sign, check allergy history before administration, explain procedure to the patient, administer diclofenac iron injection, use ventrogluteal site and Z-trunk method as I told earlier told. The dorsogluteal site is nowadays is not recommended just because of the sciatica nerve injury. The rationale, we have the pain assessed before procedure, vital sign checked, allergy history confirmed, diclofenac injection 75 mg iron administered safely using Z-trunk technique, patient monitored for adverse reaction and the pain reassessed accordingly. So evaluation is the pain reduces from 8 to 10 to 3/10. Patient verbalized, relieved, and patient appeared relaxed and comfortable, and goal is achieved. So this is my case scenario for the intramuscular injection administration. Our 25-year-old male patient, Mr. Rahul Sharma, has been admitted to the orthopedic ward with complaints of severe lower back pain following a muscle strain injury also. The physician has prescribed injection diclofenac sodium 75 mg iron. 75 mg is equal to 3 ml ml. The prescribed order is start. The patient rated pain as the 8 of the main scale. He is conscious, oriented, unable to communicate properly, and he told by himself only he feels unbearable pain. The nurse is assigned to administer intramuscular administration. So here is the preliminary assessment. Verify the doctor's orders, identify the patient correctly, assess pain level, check allergy history, assess previous injection history. If the patient is having other previous injection history, assess injection site, assess muscle mass, check vital sign, assess contraindication, which is assess patient understanding and anxiety, confirm medication expiry date, and assess mobility. Preparation of equipment, medication card to verify the correct patient medication dose with the time of administration. Sterile medication, which is prescribed by the physician only. Syringes and needles, alcohol swabs to infect the ampule top and the injection site to reduce risk of infection. Okay. assist me as qualification standard. We have patient named Rahul Sharma, and he is 25 years old. He complains uncurable pain from his back, and he having also the am I audible? Okay, now we perform the iron injection administration. जैसे कि केस सिनेरियो में बताया गया कि the Rahul Sharma is 25 years old and he is having an uncurable pain. तो हमें सबसे पहले क्या देखना है? We check the physician's order, identify our patient through his admission card, and after checking the patient and after checking the prescribed drug, we prepare the procedure. Before going to the patient, we have to prepare all the articles, all the medication in our nursing station only. So we have two kinds of tray. The articles required for the iron injection. We have the cotton swabs for cleaning the side of the patient, injections, ampules, syringes, kidney tray for discarding the veins, cotton swab, ampule cutter, gloves, and needle cutter. सबसे पहले we going to perform our procedure and we have to go with the patient and identify our patient. हम पेशेंट के पास जाएंगे और सबसे पहले इसको ग्रीट करेंगे. We all know about that procedure कि हम उसे ग्रीट करेंगे और एक्चुअल में हम उसको सिंपली और एम्पैथी के साथ ही हम उसको क्या करेंगे? डील करेंगे. तो आयरन इंजेक्शन की साइड मैंने आपके साथ शेयर करी. They have the three main sides: the ventrogluteal, the deltoid, and the vastus laterals. अभी जो मैं आपको प्रोसीजर दिखाऊंगी, I want to show you from the in ventrogluteal muscles. जब ventrogluteal muscles में हम इंजेक्शन लगा रहे हैं, तो सबसे पहले जो हम पेशेंट के पास जाएंगे, हम उसको एक्सप्लेन करेंगे प्रोसीजर. तो जैसे मेरे पेशेंट का नाम है राहुल शर्मा and he is 25 years old. तो मैं अपने पेशेंट के पास जाऊंगी और बोलूंगी कि नमस्ते राहुल, आप कैसे हैं? और वो मुझे बताएंगे कि मुझे बहुत ज्यादा पेन हो रहा है. I have uncurable pain. तो मैं उनको कंसोल करूंगी और उनको बताऊंगी कि मैं उनको क्या प्रोसीजर परफॉर्म करने जा रही हूँ. ओके राइट, आपकी पेन है और उसी पेन को रिड्यूस करने के लिए डॉक्टर ने आपको एक इंजेक्शन प्रिस्क्राइब किया है और वो इंजेक्शन हम आपको लगाएंगे और उसके बाद आपका पेन जो है वो सबसाइड हो जाएगा. एंड हम उसकी परमिशन भी obtain करेंगे. If he is either he said yes or no, and after getting his consent, we prepare our articles or procedure. सबसे पहले we should have hand hygiene. उससे पहले हम पेशेंट के पास जाएंगे और उस पर्टिकुलर पार्ट को भी हमें डिस्पोज ऑफ करना है या शो करना है जहाँ पे हमें इंजेक्शन देना है. तो सबसे पहले हम पेशेंट का जो पार्ट है सिर्फ उतने ही पार्ट को हम क्या करेंगे? शो करेंगे to ensure the privacy for the patient. और हमने ventrogluteal पार्ट को जहाँ पे हमने इस इंजेक्शन देना उस साइड को हमने एक्सपोज किया. Then after we already preloaded our vaccines. Otherwise, अगर हम जैसे वायल से हम कोई मेडिकेशन लेते हैं तो वायल से अगर आपको विथड्रॉ करना है, एम्प्यूल से विथड्रॉ करना है, तो वायल से विथड्रॉ करना है तो हमको उसमें एक एयर को क्या करना है? इंट्रोड्यूस करना है. देन आफ्टर हमें मेडिकेशन को विथड्रॉ करना है. ये क्रिएट करता है इंटरनल पॉजिटिव प्रेशर कि हमारी जो वायल से मेडिकेशन है वो क्या होगी? इजीली वायल से आ जाएगी. प्लानिंग के साथ हम स्टार्ट करेंगे। कि हम उनको आयरन इंजेक्शन देंगे डिक्लोफेनेक 75 mg, और उसके साथ ही जब हमने आयरन इंजेक्शन दे रहे हैं टेक्निक, तो हम एयरलॉक थेरेपी को भी टेक्निक को भी अप्लाई करेंगे। एयरलॉक टेक्निक इसलिए हम करते हैं ताकि जो मेडिकेशन है वो जो हमारा सबक्यूटेनियस पार्ट है उसमें ना जाके वो डीप मसल्स में ही लॉक हो जाए। तो जब हम आफ्टर गेटिंग द मेडिकेशन इन द सिरिंज हम उसमें अप्लाई करेंगे 0 to 0.1 और 0.2 ml ऑफ एयर। उसके बाद हम पेशेंट को जब इंजेक्शन लगाने चाहेंगे तो वी हैव टू क्लीन द साइट विद एंटीसेप्टिक सॉल्यूशन। एक हम जो हमारा स्वैब होगा वो हम थर्ड एंड फोर्थ फिंगर के उसमें रखेंगे बिटवीन में। और जब हम आयरन इंजेक्शन दे रहे हैं एट 90 डिग्री, तो हमें मेरे साइड आई एम सॉरी मैं साइड बता दूं। आप साइड कैसे देखेंगे वेंट्रोग्लूटियल का? Place your hand palm or heel of the palm on patient's that place जहाँ पे जो leg bone है वो hip को टच कर रही है। Then आपका जो इंडेक्स फिंगर होगा, अगर हम नॉन डोमिनेंट हाथ से देखेंगे तो जो इंडेक्स फिंगर है वो आप क्या करेंगे, जो इंटीरियर स्पाइन है आप उसमें टुवर्ड्स करेंगे एंड देन मिडिल फिंगर टुवर्ड्स योर इन योर क्रेस्ट। तो जो आपके मुंह जो साइज शेप बन रहा है, तो बिटवीन द वी शेप दिस इज द सेफ्टी प्लेस जहाँ पे आप सो, जहाँ पे आप पेशेंट को आयरन इंजेक्शन क्या करेंगे, इंसर्ट कर देंगे। At 90 degree, 90 degrees is straight. You use your syringe or needle like a dart or a pen and insert at 90 degree and slowly give your iron injection and push the injection. And slowly you can remove the needle and do not massage or over pressure on the side जहाँ पे आपने आयरन इंजेक्शन दिया है। एंड सीम ट्रैक मेथड में जब आप अप्लाई कर रहे हैं तो जो आपका स्किन होगा, तो जो आपके सेलेक्टेड साइट है उससे 2 or 3 centimeter away the side you have to pull the skin and then after you inject the needle, जिससे वो सी ट्रैक मेथड से आप क्या करेंगे, आप उसको अप्लाई कर सकते हैं आपका आयरन इंजेक्शन। And after giving the iron injection, you should not recap the needle and directly into the sharp pin. Why not recapping nowadays? To prevent the needle stick injury. To prevent the needle stick injury, we are not going to recap our needles. So this is the iron injection, and after that, I'll show you the subcutaneous method. Okay, proceed. Actually. सबक्यूटेनियस टिश्यू, जो सबक्यूटेनियस फैट में हम यूज कर रहे हैं, अगर आप इंसुलिन पेशेंट को लग रहा है या कोई भी हार्मोनल थेरेपी पेशेंट ले रहा है तो सबक्यूटेनियस नाम लगा सकते हैं 45 to 90 degree. if the patient is having a good fat तो आप 90 डिग्री में भी ले सकते हैं, अदरवाइज हम इसको 45 डिग्री पे दे सकते हैं। We have to make sure कि जो बैलेंस होना चाहिए लीडर का वो आपके आप लेवल होना चाहिए। आपने साइड को क्लीन करा और जो साइड है वो आपके अपर एब्डोमेन है, अपर आप साइड है, थाई एक साइड है, अपर स्कैपुलर रीजन। आपको स्क्वीज नहीं करना है साइड को। You don't have to be squeeze on the skin of the patient. जल्दी आपको उसको पेंच करना है, बहुत ज्यादा आपको उसे अप भी नहीं करना है, और उसके बाद आपको हल्का सा स्क्वीज करके आपको पेशेंट को इंसर्ट करके एंड इंजेक्शन आपको कर दो। And again, do not be tapping the syringe. Cannulation. कैलकुलेशन के लिए जब हम पेशेंट को प्रिपेयर कर रहे हैं तो वी हैव डिफरेंट साइजेस और वी हैव डिफरेंट साइजेस अकॉर्डिंग टू द पेशेंट। अगर हमारा पेशेंट एडल्ट है तो हमारे पास डिफरेंट साइजेस है। पेशेंट अगर हम पीडियाट्रिक है तो भी हमारे पास जो हमारा आईवी कैन का साइज होंगे वो डिफरेंट होंगे। तो हमारा जो एयर पेशेंट है और साइज These are the common sites for periculture, the IV cannulation, the median cubital vein, the sphenic vein, basilic vein, and dorsal venous arch of heart. So now I can show you the dorsal venous arch of the heart, the procedure. The patient का हमने dorsal arch of heart को select किया है for the IV cannulation. I'm not going to touching any outside thing. So आपके आपने साइड को सेलेक्ट कर लिया है कि आपको व्हाट्सएप विनर्स आज बिहान में आपको इंसर्ट करना है द कैमरा। आपको पेशेंट के हाथ को कम्युनिकेट किया एंड मेक श्योर कि आपकी जो वेट्स है, पेशेंट की जो वेट्स है वो इजीली विजुअलाइज हो सके। देन आपको ट्रायल स्टार्ट से आपने उस एरिया को क्लीन करा। And we select the size of the cannula according to the age of the patient. और जैसे आपको वेन आपका डिजायरेबल वेन मिल जाएगा, you have to pull the cannula slowly. और जैसे आपको आप देखेंगे कि आपके एज पे ब्लड आपको स्क्रीन शो हो रहा है, you have to pull it gently. चेक करने के लिए कि आप कैनुला का पोजीशन and it goes easily. Cannula secured by the adhesive tape. तो आपको मेक श्योर कि जो कैनुला है वो इजीली सिक्योर हो जाए ताकि पेशेंट के मूवमेंट से कैनुला जो है डिस्प्लेस ना हो जाए। And again the sharp objects into the right hand. And after the procedure आपने चिमटी हटा लिया और आपने जितने भी आर्टिकल्स थे उनको रिप्लेस कर दिया। और अगर जो का प्रिस्क्रिप्शन है कोई भी आईवी जॉल और फ्लूइड आपने पेशेंट को वो कर दिया करा दिया। उसके बाद जितने भी आपके पास डिस्कार्डेड आइटम्स हैं आप उन्हें डिस्कार्ड करेंगे, रिप्लेस करने के लिए आप रिप्लेस करेंगे। और उसके बाद जो प्रोसीजर आपने किया है उसको आप डॉक्यूमेंट करेंगे इन टू पेशेंट्स फाइल। So now I'm going to the special precautions. Special precautions to take injection site regularly giving the subcutaneous special documentation, record what you've done with the patient। आपको टाइम नोट करना है, जो मेडिकेशन शीट है जो भी हॉस्पिटल में की पॉलिसी है उसके अकॉर्डिंग जो भी मेडिकेशन चार्ट है उसमें आपको you have to write the injection name, the drug name, the dose, the time, the which site you prefer वो आपको मेंशन करना है। और उसके बाद जब आपने इंजेक्शन लगा लिया है जो भी प्रोसीजर कर दिया उसके बाद आपको you have to put your sign। Doing the medical कॉलेज में जो ट्रीटमेंट चार्ट है वो इस तरह से है, यहाँ पे है चार्ट जहाँ पे इंजेक्शन के लिए और मेडिकेशन के लिए डिफरेंट डिफरेंट पार्ट्स हैं। तो इंजेक्शन के लिए जैसे रूट है, the subcutaneous, the IV, the IR, RD कितने RD, the 6 RD, the 4 RD, the 8 RD, RD टाइम दिखेंगे, then किस टाइम पे किस स्टाफ ने दिया है वो अपने सिग्नेचर करेंगे, इससे ऑथेंटिकेट हो जाएगा। अगर पेशेंट को कोई प्रॉब्लम होती है तो वहां भी पता चल जाएगा कि पेशेंट को ड्रग मिला है या नहीं मिला है, एंड नर्स विल टेल द डॉक्टर्स और सुपरवाइजर्स कि हमने हमारे टाइम पे इंजेक्शन दिया हुआ है। It is a written documentation for the safety of the patient as well as the nursing office.
But next time, just remember you have to document whatever you have done as per your place map. Like when that patient name is injection the signature of you have. Like for documentation you have. On the next presentation you have shown. There are few points we need to add. So while withdrawing from the trial, so how much amount we need the injection, 2 ml or 3 ml, that amount of add only we have that we have to specify, and we know we to withdraw that. Once you are inserting through the negative pressure, it will come out. So no need to pull out. And Z-track method, only for few injection we are giving to the Z-track method like oil, like iodine injection, chem injection, not for especially for that, no need to go for Z-track method. And after just giving your site, you have to withdraw and see whether it is in your muscle or whether it is in your vein. So you have to check for the site. Or if it is in the measure, that is something or not. Then only we have to administer the medication. And when you are having the upcutter, you have to use the upcutter. And insulin site, so if you are giving for the subcutaneous injection, you have to say, see, again the same site you should not use for the insulin injection. The lipoprecin is there, so you have to rotate it. So before administering, you have to check that site also. And if you are giving the syringe, the selection of syringe also we need to specify for giving 2 ml of injection. So you have to go for, if you are administering 2 ml, then you have to go for the 3 ml syringe. So one we have to add extra. And if you are selecting the size also extra, then we have to see the fluid, the viscosity of fluid, and it is written also what syringe we have to specify. So you have to check, then only you have to select the fluid. And syringe according to the draft, the viscosity and the amount. It is written in the fluid. When you are administering fluid, you have to check already expenses. So you have to select according. The cap now. As per the additional viscosity of age and viscosity.
Huge round of applause. Can be a good source of encouragement. So thank you so much, ma'am, for the neat insight on the various procedures. We have learned the procedures once again. Next session is on care of pressure. Next session is on care of pressure source by Mr. Rohilkhand, nursing tutor from Keshlata College of Nursing, Bareilly. The education is BSc Nursing from Keshlata College of Nursing. He has professional experience of 1 year of teaching. He has published research work that says descriptive study versus the knowledge regarding dental caries. So please come.
My name is Rohilkhand, nursing tutor case with the College of Nursing, Bareilly. My topic is care of pressure sore. Today, today, my topic of care of pressure sore. Now we see this image. First of all, introduction. A bad sore or pressure sore decubitus ulcer is an ulcer occurring on the skin of any bedridden patient, particularly over bony prominence or where two skin surface press against each. Bad sore is the term applied to the local gangrene or ulcer caused by certain conditions associated with the confinement of bed due to constant pressure, circulation become slow, and finally death of tissue occurs. Definitions इसमें दिया है हमारा bad sore. A bad sore and decubitus ulcer is a localized damage to the skin and underlying tissue caused by continuous pressure, friction, resulting in impaired blood circulation. ये हमारा दिया कि जो बैड शोर है हमारे एक लोकलाइज डैमेज हो जाती है इसमें टिश्यू और टिश्यू हो जाता है जो स्किन है स्किन और स्किन के जो अंदर हमारे टिश्यू है वो डैमेज होने लगते हैं क्यों क्योंकि लगातार हमारा उस पर प्रेशर बनता रहता है हमारी बैक साइड पे उसको लगातार प्रेशर बनने की वजह से और साथ में उसमें फ्रिक्शन होता रहता है जिसकी वजह से क्या रहता है कि जो ब्लड है वो हमारा इम्पेयर्ड हो जाता है सर्कुलेट प्रॉपर नहीं होने की वजह से हमारी बॉडी पर बैड शोर होना स्टार्ट हो जाते हैं नाउ प्लेसमेंट ऑफ प्रेशर सोर in these images show which place are more chances for pressure sore arising. इस स्लाइड में हमारा दिया गया है कि कौन कौन सी पोजीशन में कौन कौन से एरियाज पे हमारे ज्यादा चांसेस होते हैं प्रेशर अल्सर अराइज होने के। फर्स्ट ऑफ ऑल इसमें हमारा दिया है सुपाइन पोजीशन, लेटरल पोजीशन एंड सिटिंग पोजीशन, अलग अलग तरह की पोजीशन हमारे यहाँ पर दिखाया गया है। Next, principle of care pressure sore. First of all, maintain aseptic technique. Keep skin dry and clean. Assess the wound regularly. Promote adequate nutrition and hydration. Maintain proper positioning. Encourage mobility and exercise. Provide pain relief and comfort. Prevent cross infection. Educate patient and family. Ensure Adequate ventilation to wound, document all observation and care, treat underlying medical conditions. Now, purpose. What is the purpose for giving care of pressure sore? First of all, to prevent further tissue damage and to promote wound healing, to reduce pain and discomfort, to prevent infection and complications, and to improve blood circulation and to maintain skin integrity. Now, indications. When patients are bedridden and immobilized or paralyzed patient, unconscious patient and elderly patient, critically ill and malnourished patient, prolonged pressure on body parts, poor blood circulation and poor nutrition status and obese patient. These are next contraindication. हमको जो प्रेशर सोर की जो केयर है वो कब नहीं देनी है, वेन रिस्ट फ्रैक्चर बर्न पेशेंट के अंदर एंड इमीडिएट पोस्ट ऑपरेटिव पीरियड। अगर कोई पेशेंट है, अगर वो पोस्ट ऑपरेट जो ऑपरेशन के बाद अगर वार्ड में एडमिट हुआ है, तब भी हम उसको केयर प्रोवाइड नहीं कराएंगे। नेक्स्ट, स्पाइनल इंजरीज, सर्जरीज ऑन बैक, एलर्जी टू ट्रेसिंग मटेरियल, अनकंट्रोल uncontrolled diabetes or severe malnutrition, osteomyelitis or deep tissue infections. Next, clinical guideline for care of pressure sore. First of all, assessment of patient and pressure relief and positioning and skin care, wound care management, nutrition and hydration, infection prevention and pain management, mobility and exercise, patient and family education, doctor documentation. Next, nursing diagnose according to priority. First, impaired skin integrity related to pressure over bony prominences. And second, acute pain related to skin injury. Third one, risk for infection related to open wound. And fourth, impaired mobility related to pelvic injury. And last हमारा इसमें दिया हमारा risk for impaired nutrition related to increased metabolic demand. नेक्स्ट, फर्स्ट हमारा इसमें नर्सिंग प्रोसेस दिया है कि असेसमेंट हम करते हैं। उसमें पहले असेसमेंट करेंगे हम, जो पेशेंट है वो हमसे हमको बोलेगा कि पेशेंट सेज माय बैक इज सोर एंड पेन। पेशेंट हमसे कहेगा कि जो माय पेशेंट सेज माय बैक इज सोर एंड पेनफुल। देन ऑब्जेक्टिव डेटा वी ऑब्जर्व, हम उसमें ऑब्जर्व करेंगे दैट ही हैज स्टेज सेकंड अल्सर ऑन द लोअर बैक एंड ड्रेनेज। देन नर्सिंग डायग्नोस, हम उसमें कुछ नर्सिंग डायग्नोसिस बनाएंगे। जैसे फर्स्ट में दिया है हमारा इम्पेयर्ड स्किन इंटेग्रिटी रिलेटेड टू प्रोलॉन्ग इमोबिलाइज। एंड उसमें हम कुछ ऑब्जेक्टिव या कुछ गोल सेट करेंगे, जिससे क्या होता है कि जो उसको प्रॉब्लम है उसको हम ठीक कर पाए। टू इम्प्रूव स्किन इंटेग्रिटी एंड प्रिवेंट वर्सनिंग ऑफ अल्सर्स, कुछ प्लानिंग करेंगे उसके लिए हम। तो प्रोवाइड अ पोजिशनिंग शेड्यूल एवरी 2 आवर्स, हम पेशेंट को हर 2 घंटे के बाद पोजीशन चेंज करते रहेंगे। अगला हमारा उसमें दिया है यूज प्रेशर रिलीविंग कुशन्स अंडर बोनी एरियाज, एजुकेट पेशेंट अबाउट मेंटेनिंग हाइजीन अराउंड अल्सर एरियाज। रेशनल, हम उसको क्यों प्रोवाइड कर रहे हैं, जो प्लानिंग है हम उसको क्यों दे रहे हैं, प्लानिंग हम क्यों कर रहे हैं उसके लिए प्लानिंग। तो उसके लिए हम देखते हैं रेगुलर रिपोजिशनिंग रिड्यूस प्रोलॉन्ग प्रेशर विच प्रिवेंट वॉर्सनिंग एंड कुशन्स रिड्यूस प्रेशर ऑन द अल्सर। एंड थर्ड हमारा उसमें दिया है हाइजीन प्रिवेंट इन्फेक्शन। इम्प्लीमेंटेशन देखते हैं हम उसमें क्या क्या करेंगे। तो रिपोजिशनिंग द पेशेंट एवरी 2 आवर्स, पेशेंट को 2 घंटे के बाद पोजीशन चेंज करते रहेंगे। प्लेस कुशन अंडर बैक एंड हील्स एंड एजुकेट पेशेंट ऑन हाइजीन एंड असिस्ट विद डेली क्लीनिंग अराउंड द अल्सर। लास्ट पर हम देखते हैं इसमें इवेल्युएशन, पेशेंट रिपोर्ट स्किन इंटेग्रिटी मेंटेन। पेशेंट की जो हम देखते हैं उसमें देखते हैं कि जो इसकी स्किन है उसकी स्किन इंटेग्रिटी है वो मेंटेन हो चुकी है। कुछ अल्सर सोच साइन ऑफ हील, और उसमें हमको कुछ साइन देखने को मिल रहा है कि वो जो उसकी स्किन थी वो हील होने लगी, उसके जो प्रेशर सोर थे वो अब ठीक होने लगे। नेक्स्ट वन में हम देखते हैं
फर्स्ट में दिया हमारा सब्जेक्टिव डेटा, पेशेंट सेज दैट आई हर्ट टू मूव, आई फील स्टिफ। देन ऑब्जेक्टिव डेटा हमारा इसमें यह है कि वी ऑब्जर्व दैट ही हैज लिमिटेड एबिलिटी टू रिपोजिशन इंडिपेंडेंट। ठीक है, जो इसमें देखते हैं हम कि जो पेशेंट है वो अपने आप से मूव नहीं कर पा रहा है।
सबसे पहले जितने भी हमको आर्टिकल दिखा रहे हैं वो सभी आर्टिकल हम क्या करेंगे, पेशेंट के बैक साइड रख लेंगे, जिससे क्या होता है कि जब भी हम प्रोसीजर करते हैं उस टाइम पर हमको कोई भी प्रॉब्लम नहीं हो पाए। तो सबसे पहले हम देखते हैं प्रिपरेशन ऑफ आर्टिकल में हमारे पास क्या क्या चीजें हैं। बीटाडीन है हमारे पास, नॉर्मल सलाइन एंड किडनी ग्रेड एंड टू वॉल्स। हमारा इसमें यह है adhesive tape, Macintosh and but the surgical gloves, gauze piece and pads। ठीक है, अगर हमारे पास दो लोग हैं, अगर हमारा असिस्टेंट है तब हम क्या करेंगे उसमें कि जो चीजें हैं उससे असिस्ट करा देंगे। अगर हम सिंगल पर्सन उसको असिस्ट कर रहा है तब क्या रहेगा कि वो चीजों को पहले से ही अरेंज कर लेंगे। सर इससे क्या रहा है कि ड्यूरिंग प्रोसीजर डू नॉट एनी फेस प्रॉब्लम, डू नॉट फेस एनी प्रॉब्लम टू बी ओपन द ग्लास and start open close piece and pads। Now we are to second step, preparation of patient। प्रिकॉशन ऑफ पेशेंट का सबसे पहले पेशेंट के पास आएंगे, उनको आइडेंटिफाई करना है बाय नेम। ठीक है, तो सबसे पहले पेशेंट के पास आएंगे बाय नेम, हम उसको क्या करेंगे, पहचानेंगे। तो सबसे पहले क्या करेंगे, मिस्टर रामू, हम उनको क्या करेंगे, नाम से आइडेंटिफाई कर लेंगे, जिससे क्या रहता है कि उनको कोई भी प्रॉब्लम नहीं हो पाएगी। हो सकता है कि सेम नाम के दो पेशेंट हो, तो हम क्या करेंगे, नाम से पहचान लेंगे। दूसरा क्या रहेगा, उनके रिस्ट बैंड बजी रहती है, उससे हम आइडेंटिफाई कर लेंगे। जो सीआर नंबर है हमारा यूएस आईडी नंबर होता है, उससे आइडेंटिफाई कर लेंगे। इससे क्या होता है कि कोई भी प्रॉब्लम नहीं हो पाए। ठीक है, हम उनके पास पहले आइडेंटिफाई कर लिया पेशेंट को। आइडेंटिफाई करने के बाद क्या रहेगा कि पेशेंट को जो भी प्रोसीजर है वो एक्सप्लेन कर देंगे, जिससे क्या रहेगा कि पेशेंट को कोई भी प्रॉब्लम नहीं हो पाए, वो अपने आप में आइडेंटिफाई नहीं कर पाए। आप उसको क्या करेंगे कि मिस्टर राम, आपके जो बैक प्रॉब्लम हो रही है उसके लिए हम क्या करेंगे, कुछ क्या करना है, जिससे क्या होता है कि आपको जो प्रॉब्लम है वो अच्छे से हील हो पाए, तो अच्छे से उसको हम ट्रीटमेंट दे पाए, हम उनको प्रॉपर समझा देंगे। उसके बाद क्या होगा कि हम कर्टेन जो भी स्क्रीनिंग है वो मेंटेन करते हैं, इससे क्या है कि प्राइवेसी मेंटेन होती है हमारी, पेशेंट को हम कंफर्टेबल पोजीशन प्रोवाइड कर रहे हैं। ठीक है, तो उसको हम पहले पोजीशन प्रोवाइड कराते हैं पेशेंट को। पेशेंट को बैक में प्रॉब्लम है तो हम उनको साइड लाइन पोजीशन भी प्रोवाइड करा सकते हैं या लेटरल पोजीशन भी प्रोवाइड करा सकते हैं। उनको पोजीशन प्रोवाइड कराने के बाद क्या रहेगा, हम मैकेटॉस को हम क्या करेंगे, मैकेटॉस लगाएंगे, जिससे क्या होता है कि जो पेशेंट की बैक सीट है उसको हम प्रिवेंट कर सकते हैं। मैकेटॉस को प्लेस करने के बाद क्या होगा, हम क्या करेंगे, पेशेंट को आपने प्रिपेयर कर दिया है, पेशेंट को प्रिपेयर करने के बाद क्या रहेगा, हम अपने आप को प्रिपेयर करेंगे, ठीक है। हैंड वॉश करेंगे, हैंड वॉश करने के बाद सीधा ग्लव्स भी वेयर कर सकते हैं। हैंड वॉश कर लिया, अब एक जो नॉन कोऑर्डिनेटर होगा उसका हम उसमें दूसरे हैंड भी ले सकते हैं इस तरह से अंडर साइड से उसके। नेक्स्ट उसका जो हम उसको क्या करेंगे, उसको हमें ऊपर से टच नहीं करना है, यू नो मैं तो अपने हैंड से उसको टच नहीं करना है। हम क्या करेंगे, जो भी हमने ग्लव्स वेयर किया है उस ग्लव्स को इस तरह से अपनी फिंगर से दूसरे ग्लव्स होगा उसके अंदर हम इस तरह से करेंगे। उसके बाद अपने हम जो भी नेक्स्ट ग्लव्स होगा उसको इस तरह से वेयर कर लेंगे, देन ठीक है। उसके बाद क्या रहेगा, हम पेशेंट को हमने पोजीशन भी प्रोवाइड करा दिया, बैकिंग और जो भी बैकिंग कॉस्ट भी कर दो, पेशेंट को प्रिपेयर कर दिया, दैट हम पहुंचते हैं नेक्स्ट फेज, हमारी परफॉर्मिंग फेज। परफॉर्मिंग फेज में क्या करेंगे, हम पेशेंट के पास पहुंच चुके हैं, जो भी उसका वुंड पहले से है उसको जो भी बैंडेज है उसको हम क्या करेंगे, रिमूव करेंगे। उसको जो भी हमने पहले से ट्रीटमेंट दिया था या जो भी बैंडेजिंग की थी उसको हम क्या करेंगे, रिमूव करेंगे। हमने उसको रिमूव कर दिया, रिमूव करने के बाद क्या रहेगा, हमारे पास येलो विंग होगा, उस येलो विंग में इसको हम डिस्चार्ज कर देंगे। उसके बाद क्या होगा कि जो हमने उसको जो बैंडेज था उसको अनकवर कर दिया है, वो होगा उसको हम देखेंगे कि उनका साइज कैसा है, उसका कलर कैसा है, उसमें कोई स्मेल तो प्रेजेंट नहीं है। ठीक है, हम उसमें क्या करेंगे, ये ये पूरा ठीक है। हम क्या देखेंगे कि जो पेशेंट है, पेशेंट का मुंड है वो कैसा है, उसका कलर कैसा है, उसका साइज कैसा है, ठीक है। उसको देखने के बाद हम क्या करेंगे, नॉर्मल सलाइन और बीटाडीन होगा, हम उसको नॉर्मल सलाइन या बीटाडीन हम क्या करेंगे, उनको अलग अलग बॉक्स में कर देंगे।
नेक्स्ट हम क्या करेंगे, फोर्थ स्टेप लेंगे। उसके बाद जो भी गॉड फिश है हमारे पास, गॉड फिश को लेते हैं हम। गॉड फिश को नॉर्मल सलाइन या बीटाडीन में डिप करेंगे। देन उसको स्क्वीज कर लेंगे इस तरह से। स्क्वीज के बाद क्या रहेगा, हम जो भी एरिया है उस एरिया को क्लीन करेंगे। एक स्टोव को, एक शैम्पू में सिर्फ एक ही बार यूज करना है, उसको दोबारा यूज नहीं करना है। जनरली हम उसको रब करेंगे, देन उसको किडनी में डिस्कार्ड करना। नेक्स्ट क्वाड्रेंट हम उसमें जो गॉज पीस लेंगे, उसको क्वार्टर हम नॉर्मल सलाइन या बीटाडीन में डिप करेंगे और उसको स्क्वीज कर देंगे। देन उसको जेंटली दोबारा रब करेंगे, उसको हम किडनी में डिस्कार्ड करेंगे। उसके बाद क्या रहेगा, हम उस एरिया को ड्राई करेंगे, उसको क्लीन एंड ड्राई करेंगे। एरिया को हमने क्लीन कर लिया एंड ड्राई भी कर दिया। जो वॉश पीस होगा हम उसको दोबारा किडनी में डिस्कार्ड कर दें। उसके बाद क्या होगा, हम एक पैड लेंगे, पैड को हम पैड लिया, पैड को थोड़ा मीठा ले लेंगे हल्का। उसके बाद क्या होगा, उस मीटर डील को और उस मीटर डील वाले पैड को हम जो भी हमारा वुंड एरिया है उस पर क्या करेंगे, कवर कर देंगे। उस वुंड एरिया का कवर कर देंगे, जिससे क्या होता है कि जो वुंड है हमारा वो जल्दी हील होता है और इजीली हील होता है। ठीक है, उसके बाद क्या होगा, इस जो टूल होगा उसको दोबारा रख देंगे। और हमारे पास अगर बैंडेज है तो बैंडेज से, अगर हमारे पास टेप है तब टेप। हम क्या करेंगे उसको, जो भी वुंड एरिया होगा उसको हम क्या करेंगे, इस तरह से टेप को कट करने के बाद वहां पर फिक्स कर देंगे। जिससे क्या होता है, जो भी ड्रेसिंग हमने की है वो एक जगह से दूसरी जगह पर नहीं पहुंचना है, वो प्रॉपर उसी जगह पर फिक्स रहेगा। ये हमने इसको फिक्स कर दिया इसी तरह से। उसके बाद क्या रहेगा कि हम उसको पेशेंट को कंफर्टेबल पोजीशन प्रोवाइड कर रहे हैं। ठीक है, अगर उसको हम ये भी बोलेंगे अगर आपको कुछ भी प्रॉब्लम होती है तब आप हमको बता देना, हम पेशेंट को कंफर्टेबल पोजीशन प्रोवाइड करा देंगे। पोजीशन प्रोवाइड कराने के बाद क्या रहेगा कि जितने भी आर्टिकल हमने यूज किए उनको हम रिप्लेस करेंगे। जो भी हमारे अगर हमको बायोमेडिकल वेस्ट में जो चीजें हमको रखनी है तो हम क्या करेंगे, अकॉर्डिंग टू बायोमेडिकल वेस्ट जो भी हमारा बीएमडब्ल्यू है उसके अकॉर्डिंग जो भी चीजें जिस बिल्डर में हमको डाउनलोड होगी हम उसके अकॉर्डिंग उसमें डाउन पेशेंट को कंफर्टेबल प्रोसेस प्रोवाइड करा देंगे। मैकिनटॉश को रिमूव करेंगे पहले हम। पेशेंट को एक कंफर्टेबल पोजीशन प्रोवाइड करा देंगे। अभी उसके बैक्स हो रहे हैं तो हम उसको मेनली अभी लेबर पोजीशन प्रोवाइड करा देंगे। तो अगर उसको जो प्रॉब्लम है वो ज्यादा नहीं हो पाए, उसके बाद क्या करेंगे, जो बैक की शीट होगी उसको हम उसको कवर कर देंगे।
पेशेंट को कंफर्टेबल पोजीशन प्रोवाइड कराने के बाद हम हैंड वॉशिंग कर लेते हैं। हैंड वॉशिंग के बाद क्या रहेगा कि जो भी हमने केयर की है उसको डॉक्यूमेंट कर देंगे, प्रॉपर फाइल में मेंशन कर देंगे। अगर कोई भी प्रॉब्लम हमको लगती है तो हम क्या करेंगे, जो फिजिशियन होगा या सर्जन होगा उनको हम नोटिफाई कर देंगे कि जो पेशेंट है उसको जो अल्सर है वो ज्यादा स्टेज के हो गए, सेकंड थर्ड फोर्थ जो भी स्टेज हमारी फोर्थ स्टेज के हो गए, उसमें हम क्या करेंगे, जो फिजिशियन होगा या जो हमारे सर्जन होगा उनको हम इन्फॉर्म करेंगे, जिससे क्या होता है कि कोई भी फर्दर डैमेज या कोई फर्दर प्रॉब्लम नहीं होता।
All of the what we have. Please give your valuable suggestions and we start. Presentation was nice, very nice, theory part, but the practical part, some of the nice presentation on the theory part, but on practical part, there are a few suggestions. I want to say practice, practice, and practice. There is one Chinese proverb, you all know, regarding the procedure, learning by doing. There is one Chinese proverb, when I hear, I forget. When I hear, I forget. When I see, I remember. And when I do, I learn. तो प्रोसीजर्स के लिए भी यही है कि हम बार 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 प्रैक्टिस करेंगे तो ये हमको आ जाएगा। रिहान के लिए मैं कहना चाहूंगी कि इसको एक ही साल का एक्सपीरियंस है, उतना इसको प्रैक्टिस नहीं है, बट बार बार आपको प्रैक्टिस करना है ताकि आप खुद प्रैक्टिस करें और वही चीज अपने स्टूडेंट्स को सिखाएं ताकि बच्चे जो है वो लर्न करने पाए। तो प्रैक्टिस आपको करना है बच्चे की। तो प्रोसीजर में जो पैकिंग थी, आपको 2 ट्रे बनानी थी बेटा, एक स्ट्राइल ट्रे और दूसरी अनस्ट्राइल ट्रे। और स्ट्राइल टेक्निक, यू हैव टू मेंटेन, डोंट टच विद ग्लव्स, gloved hand unsterile things, ग्लव हैंड पहन के आपने अनस्टेराइल थिंग्स टच किया था वो नहीं करना है। एंड प्रॉपर प्लेसमेंट ऑफ द ट्रे एंड ट्रॉली होना चाहिए था। आपने यहाँ पे ट्रे लगाई, थोड़ा उधर को लगाते और इतना ज्यादा बार बार इधर आने की जरूरत आपको नहीं पड़ती। तो थोड़ी छोटी छोटी प्रॉब्लम्स है तो वो आप प्रैक्टिस करिए ताकि नेक्स्ट टाइम आपको कोई भी प्रॉब्लम ना और आपका प्रोसीजर एक्सीलेंट हो पाए। थैंक यू सो मच। Now we can refill
source of lunchtime. It is lunchtime, it will be served in the guest house. And you can quickly go from the ground floor, take the short route exit, and volunteers will be there to escort you till the guest house. Attendees who are attending us online can rejoin us after a break of half an hour. So you have to we all have to come after half an hour. Next.